So just tell me when. Good afternoon, respected President Foxy, Dr. Sunita Tandulwarkar, Chairman ICOG, Dr. Parag Biniwale, all faculties and delegates, and welcome to this masterclass on this very interesting masterclass on emergency obstetrics and critical care obstetrics. I have the pleasure to introduce our chief organizer and convener for this afternoon, and that is Dr. Sneha Bhuyar. Dr. Sneha Bhuyar has served as the president of the Yavatmal Society. She has also held many prestigious posts and national posts as the chairperson of the Breast Committee of FOXY and the governing council member of the ICOG. She has held posts at the EMOGS as the chairperson of the Medical Disorders Committee and Emergency Obstetrics Committee and has received many awards, including the Foxy Bhira Award and the Unsung Heroes Award for Rural Obstetric Work. So Dr. Sneha is a very, very dynamic personality, and she has been the brain behind this masterclass. And I request Dr. Sneha now to carry on with the proceedings.
Yeah, thank you so much, Dr. Sarita. A very good evening to all of you. At the outset, let me thank respected Madam President Foxy, Dr. Sunita Tandulwarkar, and Dr. Suvarna Khadilkar, the Secretary General, and of course, Dr. Parag Beniwale, the ICOG Chairperson, Dr. Sarita Bhalerao, the Secretary, and the entire team, including Madam Sheila Mane, Dr. Ashok Kumar, and of course, the whole team of ICOG. Thank you so much for having us here and, giving us the opportunity as, organizer of this very important masterclass. First of all, a very happy and healthy Diwali to all of you and your loved ones. Pregnancy, all of you know that it is a physiological condition that brings on profound changes in every system of the body. And pregnancy-induced physiological changes, they often modify the disease presentation, as well as, they demand the higher level of vigilance and tailored interventions. Common conditions requiring obstetric critical care include severe preeclampsia, eclampsia, obstetric hemorrhage, sepsis, cardiomyopathies, and thromboembolism, and other organ dysfunctions. The goal is to reduce the maternal morbidity and mortality, of course, the severe acute maternal morbidity through timely intervention, evidence-based protocols, and coordinated teamwork between the obstetricians, the anesthesiologists, intensivists, and the neonatologists. So as the maternal survival increasingly depends on the quality of critical care we provide. This field represents a cornerstone of the modern or the high-risk obstetric practice. So we have selected this very experienced teacher. So friends, basically, the critical care is, a specialized discipline where you combine the critical care of the intensive care of the medicine along with the obstetrics, the physiology and pathology. And of course, here we utilize the principles of both. It focuses on early recognition and prompt resuscitation, and of course, the multidisciplinary management of life-threatening complications in the mother with simultaneous consideration of the fetal well-being. So we have selected very experienced and revered teachers who are actually the experts in the field. And that is why we have most of the professors and revered teachers here for you. So I welcome all of you. I can see almost everybody has joined here. So without taking much time, I welcome all of you, and I hand over the forum to Dr. Shobha Gudi, who will be introducing our chief guest today, Madam Sunita Tandulwarkar. Over to you, Dr. Shobha.
Thank you very much, Sneha. And at the outset, let me immensely thank the President, Dr. Sunita Tandulwarkar, the Chairperson of ICOG, Dr. Parag Beniwale, and the Secretary, Dr. Sarita Bhalerao, the Secretary General Foxy, Dr. Suvarna Khadilkar, Dr. Sheila Mane, the incoming Chairperson, for giving us this opportunity to connect with all of you on this very, very important subject. Thank you so much. It is my duty now to introduce that charismatic personality who has who has been at the helm of affairs for Foxy for the past 1 year nearly, and who has led a force of 44,000 gynecologists to do the very best for women's health. Can I have the CV of Madam Dr. Sunita Tendulkar?
Shobha, can I request you? No CV. It is our
Okay.
group only. Everyone
Yeah,
knows.
so
Thank you so much.
correct.
Because
We are waiting for your precious words, Sunita. Yeah.
ICOG is such an academic program that I don't think we should waste time in
Yeah.
introducing anyone. Just to correct you, it is not 44,000, it is 46,000 gynecologists.
46,000
with
gynecologists.
292 societies now. So
Yes.
that's a wonderful, though the societies are increasing, the number of members are remaining the same. So we need to work little differently. Coming
Yes.
to this, I think Sneha has explained this beautifully, the entire program with the faculty. What I congratulate Parag and Sarita is wisely selecting the team. See, anyone can read from the books and can give these lectures very well. But those who are in the medical colleges, the professors, the amount of cases they get, such emergency referrals from all across, definitely adds on to the clinical touch. And when the experience speak with the evidence, the things are very different. In fact, I just forwarded immediately to my all students at Ruby Hall, and I told them to join immediately. So this is such an important topic for all the practicing gynecologists. Even I see the many professors also have joined, and I think such a fantastic speakers you have selected. This will be one of the best for CME. I always feel that is how it is. Thank you, Parag, your team completely with Sarita, Sheila, and everyone working so hard and coming out with the fantastic CME. Only your timings are, so many times I feel even I want to attend, but 4 o'clock is a peak time for the consultation. So we miss out on many. But nevertheless, thank you so much for having me here. Thank you. And I invite all of you to Sampurna November conference. Please be there, enjoy. It's a fantastic scientific program. Pune OBGY Society has worked very, very hard for it. On 14th, there are 10 workshops, and 15th and 16th is a conference. I humbly request all of you to join. Thank you.
Thank you so much, madam, for your inspiring words always. We are very happy and privileged to have you as a chief guest. Now I invite Dr. Vidya Thobi to invite the dignitaries and of course to have their precious words.
Yeah. So good afternoon. As I'm again thankful to Dr. Sunita, Dr. Parag, and all the ICOG office bearers. I will not take much time. I invite Dr. Parag Biniwale to say a few words about the workshop, and the people will definitely would like to know why we have done this masterclass series. Yes.
Thank you, Vidya. Good afternoon. I bring greetings from ICOG, and it's indeed a pleasure to address the audience today for this month's masterclass. And the theme this time is critical care in obstetrics. Now, all of us will agree what Sneha has said is that the patient profile is changing, and we do get to see a lot of high-risk women, and it is important for us obstetricians to understand the nitty-gritties of management if these patients become really critical. So I appreciate the efforts put in by the conveners, Sneha, Shobha, and Vidya. And thank you all the faculty. I can see who's who in of the critical care. Thank you, Pratima, Prakash, Girija, who are the doyens in this field for joining. And I warmly welcome past President Dr. Suchitra Pandit. Thank you, Suchitra, for always being there to encourage us. And Sunita, special thanks to you because, as I said, the president's presence always encourages the members to do better. Thank you very much, and happy
Yes,
learning, everyone.
definitely.
And I'm looking forward to some great learning sessions today. Thank you.
Yes. Thank you. Thank you, Dr. Parag.
Thank you. Thank you so much, Parag, for having us here and of course
Sneha,
encouraging us.
Sneha, can I just say a few words before we go ahead?
Yeah, no, we
Yeah,
have
I
Dr.
just,
Madam. Yeah, you will speak it. We have Madam Suchitra Pandit
yeah,
as guest of honor.
okay,
So we
okay.
will have her words first. All of you know her so well.
Yes,
Past
yes.
president of FOXY, past president of ISROPA, of course, president of India chapter of Justices, and she has headed so many organizations, have had so many awards, including the FIGO Achievers, Women Achievers, and of course, a mentor to many like me. So I welcome Madam Suchitra Pandit for her words. Over to you, Madam.
Thanks, Neha, and thanks to the ICOG for creating this wonderful series. I was recently at the FIGO conference in Cape Town, and we stand proud in a way that our MMR has gone significantly down as compared to a lot of Western, the African countries and a lot of countries in Europe. We are much better off than them. So, what actually helps us? Obviously, we've followed all the wonderful protocols for acute emergencies, but now it's time that we use all our efforts and all the expertise to save our mothers who are critical. So, the near misses should be saved, and that's where we will start improving more and more. So, we're looking at quality healthcare as well as looking after the critical, situations. And it's wonderful thought process that Sneha, Vidya, and Shobha have put together, and good that Parag and Sunita have agreed for all this wonderful program, and of course Sarita as the secretary of the ICOG. So congratulations! I saw the names of all these people, and Parag has already mentioned them. So it'll be a wonderful learning. Stay on and hook. And I think ICOG should keep this thing going on because we are a great body for learning, and Zoom is such a wonderful platform that this move should be continued even after Parag finishes and Sheila takes over. Thank you very much. On all the best to the ICOG series for today, and thank you, Sneha, for making me a part of it. Thank you so much.
Parag, can I say something?
Yeah,
Since Suchitra has said I made it on, I was hearing, you know what? Actually, every one of us should feel very proud. In 30 years, we were 550 plus our maternal mortality rate,
correct.
and we came down by 86% decline to 80. And the global decline rate in this last 30 years is 46%. So the amount of work the government sectors, of course, the private sector also, but the public sector and the government has put in. Of course, the time doesn't allow this, but when you said we have come down, it is a very, very important thing. And another very great thing which has happened is if you see the statistics, 98% are now institutional deliveries, whether in public setup or the private setup, and only 2% are happening the home delivery. That has made a lot of change
Lot of
with the
difference.
government's lot of incentives. Thank you.
Yeah, thank you. Sneha,
Thank you, Sunita.
I just wanted to thank you. Thank you specifically for taking a lot of load for this masterclass on your shoulders and connecting with so many experts and crafting this beautiful program. For the name, all three of us are there, but I think Vidya agrees with me that you have been a gem and you have really brought mainly your thought processes. We really thank you for taking all the trouble and also wishing you all the best. Thank you.
Thank you so much. And with this wonderful galaxy of speakers, I think we should not waste any moment, and we should go ahead with the academic sessions at the earliest. So I would like to thank once again all the dignitaries here, and thank you the entire team of ICOG, Madam Sheila Mane, Ashok Kumar. I think Madam was not there when I initially welcomed, and thank all of you. So once again, I thank everybody, and let us now move towards the academic session. Thank you so much. Over to you, Dr. Vidya.
Thank you. Let us move ahead for the first session. And the first session, chairpersons are Dr. Arun Arora, Dr. Rajashri Katke, and Dr. Aruna Suman. So the first session intends to mainly starts with Dr. Girija Wagh, that is Dr. Physiological Changes of Pregnancy and Implications in Critical Care. So I just introduce our chairpersons to the audience. Dr. Arun Arora is a ex-head of the department, Government Medical College, Udhampur, Jammu and Kashmir. And now he is a visiting professor. He does the visiting professor fellowship, also ICOG. He is the inventor of Pushpanjali technique of cesarean in deeply engaged head and course director for the Akshar postgraduate teaching programs, national advisor for Indian Fertility Society, advisor for the Jammu Obstetrics and Gynecological Society, president of Society of Vaginal Surgeons in India, Jammu, and contributed many chapters in the books with over 3 decades of clinical and academic excellence, and he is committed to the elevating women's healthcare across India. So welcome, Dr. Arun Arora. I want second CV as well, Dr. Rajashri Katke. Dr. Rajashri Katke, we all a well-known figure in Foxy, as well as she's a dear friend of mine. She's a professor and head of the unit, former HOD of Grant Medical College, ex-superintendent of Kama and Alblaze Hospitals, Mumbai, renowned obstetrician and gynecologist and surgeon par excellence. We know all her books, 100 plus publications, and she has got many awards and credits and recipients of many awards. And she has specifically Best Superintendent Award and Best Associate Professor of Rajiv Gandhi Excellence Award. Our third chairperson is Dr. Aruna Suman. She is a professor of OBG Government Medical College, Chaktal, Telangana, and organizing secretary of AICOG 2024, national coordinator for No for to Walk Committee 24 to 26. We know her very well. She also has many awards to her credit. So over to these three chairpersons to conduct the session, and I ask Dr. Arun Arora to introduce Dr. Girija Wagh, the first speaker.
Thank you, Vidya ma'am.
Dr.
Thank
Arun
you.
Arora. Yes, sir.
Yes, ma'am.
Yes,
Thank
sir.
you, Dr. Neha.
Yeah.
Thank you, everybody from ICOG. The first speaker is Dr. Girija Wagh. She's professor and head Department of Obstetrics and Gynae, Pune, Director Primrose Wellness and Care Center, and she consults in Bharti Hospital, Primrose Wellness and Care, Cloud9, SB Road, Apollo Sector, Swargate. For her professional highlight, she's a veteran gynecologist, medical consultant. Yeah.
I think we'll go ahead with the.
Yeah, she has all the awards and all accolades with her.
Girija has got so much big CV. Yes.
Yes, ma'am. Yes. Welcome, Girija ma'am.
Can I share
Welcome,
my presentation? Yeah.
Yeah.
So thank you. It's indeed a privilege to be here in this critical care workshop. And thank you, Sneha, for giving me this opportunity. And thank you, ICOG, for creating this stage for all of us. And I'm sure in this particular task, especially can you see my presentation?
Yes.
Yeah. So especially of speaking on very, very basic issues of physiological changes in pregnancy and implications in critical care is something which is very close to my heart, something which I speak about maybe on my day-to-day practice here with my residents as well as my students. And thank you for that very kind introduction, chairpersons. And I'm indeed privileged to have you as my chairpersons for this particular session. So we all understand that pregnancy is a stress test of sorts, and it is a physiological stress test. Every system, the cardiac, respiratory, renal, hematological, undergoes major shifts. And these adaptations ensure, basically they are for a purpose, survival, fetal survival especially, but may challenge us in critical care interpretation of the maternal health. And that is something which is important. Of course, these adaptations have also been made to protect the mother, because she should be able to overcome those changes and challenges that can probably lead her to become morbid or die. And therefore, these adaptations are actually protective. So today we are going to explore how pregnancy physiology impacts critical care decisions, how these changes are adaptive but can mask pathology or mimic diseases, and understanding them is key to saving lives in the obstetric ICU. So One very important thing and the objective that we have to follow all the day in our every such kind of a clinical situation is first, review the system wise changes. Second, link them to ICU management. And third, learn how to differentiate normal pregnancy physiology from early signs of deterioration. And this is something which is extremely important, tough, and requires a lot of suspicion, astute, or observation to that particular condition. Now, the commonest one which has always been spoken about is the cardiovascular changes during pregnancy. We all know
Girja, are your slides moving, Girja? It's not
yeah,
moving.
I can see them here. You're not seeing?
No, your
Moving is not
slides are
happening.
not moving. They are not
Are they
moving.
moving?
First slide is on.
Huh? But
Introduction slide is there now.
should I again stop and reshare? Yeah, I'll do that.
Yes.
What happened? So can you see the slide now of
Yeah,
objective?
yeah, we can see.
Yes.
Now, are you able to see the cardiovascular?
Yes.
Yeah.
Now they are.
So, okay, fine. Sorry for that glitch. So we all know that the cardiovascular changes are profound and we are well aware of there. There is increase in the cardiac output, about 30 to 50% increase heart rate, reduction in the systemic venous return. Blood pressure is slightly reduced in the mid-pregnancy. And this cardiac output rises by up to 50%, heart rate by 10 to 20 beats. And systemic vascular resistance drops, so BP falls slightly mid-pregnancy. And this would matter in the ICU where tachycardia, mild hypotension may be normal and may be sometimes mislabeled as shock. Sometimes we may be seeing that she is in shock and we may mislabel them as normal. So frequency is there increase in the stroke volume, blood volume. There is reduction in the peripheral vascular resistance. There's increased myocardial oxygen consumption, vascular changes, hypercoagulability state. Because of the increase of level of thrombin, activity of anticoagulant factors such as protein C and S, and fibrinolytic activity. And we all know these are protective mechanisms for the mother. And levels of elastin and relaxin and collagenollytic activity is also known to increase. So whenever I speak in all our post-morbidity meetings, we always talk of this particular thing, that pregnancy comes with a lot of tissue factors in it, lot of changes into it, and we really require to look at it very, very carefully. So when we look at it pregnancy duration wise, let's say trimester wise or weeks wise, we can see that there is an increase in the stroke volume, which is gradually so and becomes profound somewhere around 16 weeks, 24 weeks, 32 weeks, and then plateaus. Then likewise, there is changes in the heart rate and the systemic vascular resistance. So all these things we should be aware and have to interpret in the context of the gestational age. Typically, if you look at the changes in the blood pressure during normal pregnancy, you'll find that the BP reduces in the first trimester, SVR reduces as well. In the second trimester, it is a nadir of about 35%, while it is reduced SVR. And in the third trimester, there's increase back to pre-pregnancy baseline and 20% below the pre-pregnancy baseline. There are also changes in the heart. Like the LA diameter increases 0.4 centimeters. There is a 13.6% relative increase compared to the baseline. Aortic annulus does not dilate from normal physiological changes of pregnancy. Left ventricular hypertrophy, there is a 23% increase in the mass from first to the third trimester, and there is 50% increase in the mass at term. And annular diameters of the mitral, tricuspid, and the pulmonic walls also increase. Now, this is very important to understand because many a times we are now doing maternal echo in patients, especially who are at risk, such as obese women, hypothyroid mothers, diabetics, women with heart disease, hypertension, or generally as sometimes as a screening test for all pregnant moms to ensure that their adaptations have not gone beyond limits. And these would then extrapolate into our physical examination findings and ECG findings, such as systolic ejection murmurs, enhancement of the fetal heart sound, possible tricuspid regurg, mitral regurg, and pulmonary valvular regurgitation, possibly S3, S4 sounds as well because of the hyperdynamic circulation, shorter PR and Q2 intervals on the ECG, right shift of the QRS axis in the first trimester and left shift in the third trimester, and possible depressed ST segments and isoelectric low voltage T waves in the left-sided precordial and limb leads. So these have to be factored when we are trying to interpret these patients. So whenever we are looking at the critical care implications in context of the cardiovascular system, we have to remember that baseline tachycardia may not be always shock. Blood pressure drop may mask preeclampsia. Fluid overload, we will always say, your BP was perfectly normal, but then there has been some problem where it got masked. Fluid overload risks are profound in pregnancy because it's sort of a leaky capillary syndrome. And therefore, if you look at the heart rate of 100 to 110 is normal, more than 120 with hypotension signals trouble. BP drop can mask preeclampsia, and therefore we have to keep a watch on the trends. And fluid resuscitation, we have to be extremely cautious in these pregnant women because they can quickly get into pulmonary edema. And we have also seen pulmonary edema occurring without any external fluid, especially in women that I named just now as high-risk mothers. So one has to keep these kind of graphs in front of our eyes, like FSC capacity, minute ventilation, cardiac outputs, blood volume, and glomerular filtration rates, because all these systemic things are interlinked, and there is always a challenge of these women undergoing changes, profound changes in their colloid osmotic pressures, and postpartum autotransfusion after delivery, or if you give them fluids, they may go into pulmonary edema. Respiratory changes are also of great importance because there is increase in the tidal volume. You can see that this is the non-pregnant patient and this is the respiratory volumes in the pregnancy, where the increased tidal volume supports higher minute ventilation, mild respiratory alcoholism with PaCO2 around 30 millimeters of mercury. Reduced FRC is seen means less oxygen reserve and rapid desaturation during apnea or intubation. Total lung capacity slightly reduced due to diaphragmatic elevation, but vital capacity remains stable. And this would all therefore mean that whenever we are looking at the minute ventilation increases, PaCO2 decreases to about 30 minutes of mercury, functional residual capacity decreases, leading to rapid desaturation, and PaCO2 more than 35 in pregnancy indicates impending respiratory failure, and that's how we have to be careful when we interpret them. Because this pulmonary physiology in pregnancy, if you look at the anatomic and the functional effects, hormonal changes in pregnancy affect the upper respiratory tract and cause airway hyperemia and edema, many times resulting in symptoms of rhinitis, which may interpret as cold. Estrogens are likely responsible for many of these effects because they produce capillary congestion and mucus gland hyperplasia. Changes to the thoracic cage results from both the enlarging uterus and the hormonal effects which produce ligamentous laxity. And the diaphragm, we all know, is displaced cephalad by up to 4 centimeters, but the potential loss of lung capacity is partially offset and by an increase in the anterior, posterior, and the transverse diameters, and by widening of the subcostal angles, and that helps them. So we can see that there are various kinds of anatomical changes which occur because of the growing uterus, and these can extrapolate into various needs, and underlying this all is the increased oxygen consumption and CO2 production, which is because of the altered metabolic changes in the woman's body. Renal changes are also very, very commonly seen. We all know that there is increase in the GFR by 50%, decrease in the serum creatinine about 0.4 to 0.6 milligram per deciliter, increase urine protein excretion, mostly because this is because of the increase in the perfusion. So renal physiology, GFR increases, so creatinine falls to 0.4 to 0.6, and there is increased sodium retention. And this has to be looked into in a critical situation. Creatinine more than 1 milligram per deciliter is significant renal compromise. Don't apply non-pregnant thresholds. So these are typically the changes as we see. There is increase in the blood volume and the cardiac output, fall in the systemic blood pressure, decreased systemic resistance, increased levels of vasodilators, resistance to vasoconstrictors, lower plasma osmolarity to the tune of 270 millos per kg. And then there is, of course, another pressure which is coming from the physiological hydronephrosis. And this would also extrapolate into increased uric acid excretion and physiological glycosuria also, which we must be aware of and interpret correctly. So when we look at the anatomical changes that occur in the system of the renal system is there is increase in the kidney volume by 30% due to nephron hypertrophy, not hyperplasia. Renal perfusion is increased by 30%. Hydronephrosis is common, typically seen on the right side more than the left, probably because of a mechanical compression by the ovarian venous plexus or the increasing uterus or the change in the angle. And this usually resolves postpartum, not pathological. Pregnancy enlarges kidneys by 30%, mainly from nephron hypertrophy. And this has to be remembered. And you can see an X-ray here, a pylography, which is showing that the right-sided hydronephrosis. And we have had patients getting admitted because of pyelonephritis and so many of renal calculi and hydronephrosis and everything compounding together and getting into complications. So when we look at the hemodynamic changes and GFR impact, because of the vasodilatation, relaxin plus nitric oxide, there is activation of the RAS system, where there is extra renal renin from ovary and residua, increasing angiotensinogen, that is estrogen effect, and the placenta also has an independent RAS, and this will give rise to all the changes that we are seeing in the form of increased plasma volume, 30 to 50%, sodium retention, and reduction in the sodium. GFR would be increased to 40 to 50%, creatinine would be 0.4 to 0.6, we realized, and proteinuria less than 300 milligram per day is taken as normal. And you can see that there are week-wise changes which are all interlinked between the renal, the cardiovascular, and the hematological systems. So what is the role of this RAS in pregnancy, the renin-angiotensin-aldosterone system? It's a key hormonal cascade that regulates blood pressure, fluid balance, and sodium retention. And it gets activated because of the systemic vasodilatation. I don't know what is this. During pregnancy, lowers blood pressure.
The alarm that your time is up in 2 minutes.
Okay, then should I stop?
But we are listening. It is very interesting. Yeah.
You want me to stop or continue?
Chairperson.
Continue.
I will
She can finish.
There's very little is remaining. Okay.
Yeah. You please complete.
So it lowers the blood pressure, triggering RAS to maintain perfusion. There are pregnancy-specific changes such as extra-renal renin secretion from ovaries and maternal decidua, increased angiotensinogen, which is synthesized in the liver due to high estrogen, and placenta has all the components for independent RAS activity. And these would cause steady increase in the aldosterone from week 8 to 3rd trimester, causing sodium and water retention. And plasma volume will increase by 30 to 50%, but serum sodium slightly reduces 130 to 135 mole equivalents per liter due to dilution. And this has to be remembered in the clinical context that there is an imbalance may contribute to preeclampsia, and increased aldosterone and ADH lead to volume expansion supporting uteroplacental perfusion. So it's with a purpose, but sometimes it can be pathological. And these are the typical charts and the numbers which you need to see. I'm not going to go through the details because we don't have so much time. In between the non-pregnant and the pregnant, while you're interpreting your hematocrits, creatinine, and all these levels, you must be looking at these values correctly. There are tubular functional changes also, as we discussed, and glycosuria can occur at normal glucose. Hematological changes are there not only because of increased plasma volume, but there can be hypercoagulation also on the other side, and this would cause challenges. We know that there is hemodilutional anemia, which is very common. Platelets may reduce. Erythrocyte mass reduces. Coagulation factors, some will increase and some will reduce. And they can also contribute to various hematological complications such as IDA, bleeding disorders, thrombocytopenia, and thromboembolism. Metabolic changes have to be remembered, such as reduce in the gastric motility and delayed emptying. This is all because of progesterone giving rise to relaxation in the esophageal sphincter, increased metabolic rate by 15 to 20%, and progressive insulin resistance because of the placental hormones, lipolysis and free fatty acids in late pregnancy, mild respiratory alcoholysis, and serum osmolarity. And these would have clinical implications such as high aspiration risk during intubation, careful glycemic control in ICU, especially when you're giving steroids or in the situation of sepsis, adjusting fluid and electrolyte management correctly. Delayed gastric emptying increases aspiration risk. And we have to remember that glycemic control can become a challenge. There is also a lot being spoken about the changes which also happens in the microbiome population, especially more profound in the 2nd and the 3rd trimester, as well as like the vaginal microbiomes, there can be a change in the gut microbiomes as well as the oral microbiomes. So in conclusion, we have to remember that physiological changes in pregnancy have to be interpreted correctly. Always use the correct reference ranges and keep them visually available so that you are there interpreting it in a situation of critical situations. And in summary, I would like to say pregnancy physiology versus pathology has to be carefully seen, should know the baseline to act early. Key takeaway is pregnancy physiology is unique, recognize normal to detect deterioration early, and the knowledge saves lives in obstetric critical care. Thank you so much for giving me this time, and happy Diwali. And I wish I was warned that there's going to be an alarm so that I would have planned. Thank you.
थोड़ा कंक्लूजन स्लाइड नहीं आया फिर से.
Conclusion ऐसा था कि actually I would have told you a case, Vignet, because many times we keep on erring on positivity, and recently we lost a mother to sepsis, and the conclusion post-death audit what we had with the stakeholders was that probably we did not realize the pathological changes that occurred in the mother. The cytokine storm happened to her because all her parameters were masked by whatever interventions we were doing. So therefore, it's very important that we look at these things correctly. We are talking a lot about PPH, but sepsis, we are still faltering. And we should have a low threshold of taking decisions like doing a hysterectomy, even if everything seems to be normal. Because finally, the cytokine storm, which came in my patient after 24 days, she had come from outside, not done with us. She succumbed to that. And the source probably was coming from the uterus, which we never found on imaging. So therefore, be vigilant is what would be my message. And I'm extremely saddened because this happened just 3-4 days back. And we feel that we are always there monitoring, putting them on machines, everything, but somewhere we really make mistakes because pregnancy and especially postpartum period will modify those changes. We have to be astute enough to diagnose that something's going wrong.
Very true, Dr. Girija, and there is very thin gray line between when the physiology changes to pathology. And once we don't know the exact physiology, then pathological parameters also to take some decision becomes very, and it is all obstetricians to know physiology and pathology is really good. I want Dr. Arun Arora to comment on this as a chairperson.
Yes, ma'am. Excellent presentation, Girija ma'am. The only thing which I am interested is when we are looking for all these physiological changes, usually the nature prepares a body for for the benefit of it. But there's a very thin line when they turn to abnormal story.
Correct.
So one is we have to be very careful in interpreting these changes or the values which are there, physiological values in pregnancy. One thing which I always find is when we are using ratios, then those things probably give us a better indicator, like maybe a shock index or for that matter, any scoring systems, then probably these physiological mismatches go away. So that should be for everybody in all institutions. Like maybe you put the whole of Mayo score or the shock index, no, then these individual findings go away. And the second part is the role of these things in critical care is more important because suppose you are doing a maybe a CPR or something like this. There these changes are more important. So because everything is pressing on uterus, the aortocaval compression, they all go. So one has to be very careful in doing a CPR. Maybe you turn lateral tilt, or those things are really important at that point of time. And as far as all those changes of coagulation factors, although they are again important in preventing, nature is trying to protect from PPH, but slightly derangement of these things lead to thromboembolism. So maybe early ambulation or all those things are important. So these are small points which probably help in critical care patients. Generally, it's okay. So when patients is real critical, these values or these ratios, one part, and second part is how to resuscitate at the time of like simple respiratory changes we are talking is maybe we have a nasal edema or laryngeal edema, then you are trying to put a endotracheal tube, and that may be difficult. So those things have to be kept because these physiological changes create a problem in those, your maneuvers. So you have to be slightly careful. Thank you so much.
Yes, thank you so much, Girija, and thank you all of you. I think Vidya, we can go ahead with the
We can
second
go
talk.
ahead.
Yeah.
I request Dr. Rajashri Katke to introduce the second speaker.
Yeah, it's a proud
Dr.
pleasure.
Prakash,
To introduce Dr. Prakash Mehta, sir. Sir is BSc, MBBS, DGO, MD, DNB, and Diploma in Medical Law. He has a Chief Division of Maternal Fetal Medicine and Head of the Department of OBGY at Bhagwan Mahavir Jain Hospital, Bengaluru. Sir is postgraduate and post-PG fellowship teacher and examiner in maternal fetal medicine in OBGY. He has a numerous articles in various journals, contributed to the chapters on the maternal fetal medicine in many books, delivered many orations in the field of maternal fetal medicine at various places, and he was a president for the Society of the Maternal Fetal Medicine in India, past president of the Bangalore Society of the Obstetrics and Gynecology, and past joint secretary of the FOXY. So I think sir has even the diploma into the medical law. So sir will highlight about the topic, also correlation with the legal things. I think, sir, the floor is yours now.
Sure.
Please
Thank you.
continue with that.
Yeah, thank you very much for having me on this forum. I thank ICOG and to especially thank Dr. Sneha because she chased me till I said yes.
Yes.
Okay. Now, the topic today is approach to acute respiratory failure in pregnancy. This is one of the, I wouldn't say a very common kind of a situation that we face, but something that you're going to see sometimes definitely in your life. Now, we know that the pregnancy is the most wonderful experience life has to offer, but it can also be the most dangerous. We start with turmoil, then the turbulence comes in, and finally the transition comes in because our patients are very young. They respond to the treatment if we give at correct time and in the correct form. They respond extremely well. ARF affects up to about 0.2% of all pregnancies. Now, it's more common in the postpartum period. And there are basically two types. One characterized by hypoxemia, where the partial pressure of the oxygen is less than 60 millimeters of mercury, which is called as the type 1. And the other one is a hypercapnia, where there is a PaCO2 of more than 50, which is type 2. Now, the acidosis invariably accompanies the type 2 kind of a hypoxemia. And the pH, we all know that during pregnancy is a little bit on the higher side. So a pH of 7.35 indicates quite a bit of acidosis. The altered maternal respiratory physiology, we have been talking a lot about it, or Girija gave a wonderful exposition of it, affects the assessment and management of these patients. We have to be very careful. Now, this was one of the patients who had just come to me about 4 days back. She's a 28-year-old obese patient. She had twins, preeclampsia, possibly health syndrome. She underwent an LSAF outside at 4:30 p.m. on 10/10/25, and she was referred at 4 a.m. to my maternal fetal medicine unit with dyspnea, SpO2 of 78%, and the respiratory rate of 35 per minute. And this is a chest X-ray, classical picture showing what is the cause for her dyspnea. You can see the cotton wool patches everywhere. So this is a typical pulmonary edema that she had. This is her ABG showing that yes, she was in hypoxemia only. She has not yet gone into hypercarbia, and we put her on a non-invasive ventilation, and the patient settled extremely well in the next 24 hours. Of course, with a massive dose of Lasix being given to her. So the clinical presentation of the respiratory failure, the most important symptom is dyspnea. We all know that dyspnea is very common in pregnancy. Most of our patients will tell you that I'm breathless. But worsening dyspnea associated with some other signs has to be taken as pathological. Don't put it as physiological just because the patient has been complaining right from 6 months onwards that she's not able, she gets breathless when she walks or something like that. Tachypnea, more than 20 breaths per minute, is very important. Unfortunately, what I've observed is that most of our obstetricians, we don't concentrate so much on respiratory rate, which is a very, very simple test. And if there is a tachypnea, please do not ignore this patient. Hypoxia, the SpO2 less than 94%. If you can see the accessory muscle use, and you can, if there is an altered mental status, especially this occurs more with hypercapnia rather than hypoxia. But if there is a about this patient. So what is the diagnostic approach that we can have? The most important step is history. The onset, the duration, the associated symptoms. Is there a fever? Is there a chest pain? Is there a cough? Are there any comorbidities, asthma, cardiac disease, thrombophilia? When you can start thinking whether there has been a pulmonary embolism. The medications, is she on magnesium sulfate? Are there opioids? Is she on sedatives? The obstetric history. And then comes the physical examination, the vitals, especially, I repeat again, the respiratory rate, the work of breathing, look for nasal flaring, accessory muscles, the auscultation, look for wheezes, crackles, decreased breath sounds, and look at the legs, whether there is any swelling, there are any signs of DVT. And of course, look at the uterus also, because the uterine tendons and contractions will tell you that there could be an obstetric cause. The lab workup, again, is quite simple and quite straightforward if you follow it. ABG, of course, is mandatory. It is a key to detect subtle hypercapnia. The total blood count, look for leukocytosis. The CMP, look for the renal function like preeclampsia, HELLP syndrome. The BNP to differentiate pulmonary edema from other causes. Do the troponin, ECG, echo for suspected cardiac etiology. D-dimer is very non-specific. It is always elevated in pregnancy. So an abnormal D-dimer value is of no use in pregnancy. Please do not use it to correlate with pulmonary embolism, because D-dimer is always high in pregnancy, especially after a cesarean section. Magnesium levels, if you are suspecting toxicity, and electrolytes, LFT and lactate to rule out both preeclampsia and sepsis. Now, little bit, like, of course, I can't go into too much details of ABG, but we need to know a little bit about ABG, that the normal values are 7.4 to 7.46, like they are more towards an alkaline kind of a pH during pregnancy. The PCO2 is 26 to 32, PO2 is 101 to 106, which is slightly elevated. The bicarbs are 18 to 21. Now, when you do evaluate an ABG, first look at whether there is an acidemia or is there an alkalemia. Is the primary disorder respiratory or metabolic? Once respiratory is diagnosed, look for acute or chronic. For respiratory problem, is the metabolic compensation coming in? Is that metabolic compensation appropriate is what we need to check. And for metabolic disturbances, look at the respiratory compensation and see whether it is able to neutralize the metabolic effect. And if there is a metabolic acidosis, then we need to go at the next level, that we need to calculate the anion gap. Now, it is important to interpret arterial blood gases during pregnancy with an awareness. I repeat again, because this is very important. A lot of time mistakes are being done when an ABG is read, is that the pregnancy physiology results in a compensated respiratory alkalosis. A PaCO2 of 40 millimeters of mercury, which is considered normal in a non-pregnant patient, is concerning for progressive respiratory failure. So we need to keep this in mind, because our patients should show a PCO2 of only between 26 and 32. So a 40 is definitely abnormal. Imaging. The first imaging technique to be done is the chest X-ray. Now, when we do a chest X-ray, the exposure to the fetus is to the order of only 0.01 to 0.03 milligrams. It's absolutely safe in pregnancy. Do not hesitate to do a chest X-ray whenever it is required. We know that the radiation thresholds for the fetus should be less than 50 milligrams. Now, I'm talking here of only 0.02 milligrams. So it can be easily done. The CT pulmonary angiography is the gold standard for identifying pulmonary embolism. Now, this has a little more higher dose of radiation, but it has to be done if I have to prove that there is a pulmonary embolism. The VQ scan can be done as an alternative if chest X-ray is normal to avoid CTPA. But I repeat again, CTPA is the gold standard. Then we have the POCUS, that is a point of care ultrasound examination, which is now becoming very important. You can do the lungs POCUS, where you can see the B lines for edema. You can see the consolidation if there is an infection. You can look at the heart for peripartum cardiomyopathy or a tamponade, and look at the leg, lower limb Doppler for DVT as a source of pulmonary embolism. The fetal assessment is important. Fortunately, as I already told you, most of the acute respiratory failures come in the post-delivery phase, but there are any number of cases. I'm sure all of you would have seen patients with COVID when there was a respiratory failure during pregnancy, and a continuous fetal monitoring has to be done if she's greater than 24 weeks. That is the period of viability. Assess both the fetal heart rate as well as the movement. So with this, we go quickly through a few cases to show the different kind of etiology that would come for acute respiratory failure. So the first case is the story of a 23-year-old primigravida. The patient was not from my place. The patient was from the neighboring state, about 4 hours away. And she went in for a routine check, and she was told that she's in labor and admitted, and she was induced. Then she was augmented with oxytocin at 11:40 a.m. And somehow, I don't know, they used Drotin and Epidocin. I hope none of you are using Drotin or Epidocin anymore. But there are certain centers still using, in spite of knowing that this should not be used, every half an hour for 2 to 3 doses. And she also received an antibiotic, cephalosporin. Following which, the patient had 2 episodes of bleeding, and then she developed a swelling of the whole body and face. The pulse was feeble. There was a tachycardia, 130 to 150. BP was not recordable. Multidisciplinary care was given. That place, fortunately, had a multidisciplinary team. Anti-shock treatment, steroids, inotropes, everything was given. Patient's condition stabilized, but the baby by this time was already dead. The patient's relatives were informed that there was an IUD. The labor was then augmented, and the forceps-assisted vaginal delivery was conducted, and a stillborn male baby of 3.5 kg delivered. Following delivery, patient had 1 episode of vomiting followed by unconsciousness after half an hour, and the uterus started intermittently relaxing with bouts of fresh bleeding. The patient's condition deteriorated. Transfusions, inotropes were started. It was found that the hemoglobin was only 4 grams with unrecordable BP and feeble pulse. And then this patient was referred, of course, accompanied by an anesthesiologist and ventilated in a state of shock with a possible diagnosis of amniotic fluid embolism, a DIC, and PPH. So on admission, there was already that given enough blood transfusion. So by the time she came to me, the HB was about 12.5. We established an arterial line. ABG done, showed metabolic acidosis. The patient was ventilated. The blood pressure was maintained by inotropes. There's especially noradrenaline is the best inotrope we can use in our patients. And she was started on higher antibiotics. Chest X-ray done, showed increased bronchovascular markings. Echo done to rule out cardiomyopathy. It was within normal limits. And the patient responded extremely well. Next day, she started going on the Riles tube feeding. Her condition improved, and patient could be extubated after 24 hours. And this was the happy patient whom I sent home at the end of 8 days. So this was a typical amniotic fluid embolism, which could go home. The second case was a 29-year-old para 2 living to abortion 2, referred for tertiary care post LSCS with eclampsia, HELLP syndrome, acute renal failure, and pulmonary edema. I'm sure all of you would know that acute renal failure and pulmonary edema often go hand in hand together. And look at her ABG. You can see that the pH is only 7.292. So she's definitely acidotic. And of course, the X-ray shows a typical pulmonary edema. Now, because she was HELLP syndrome with pulmonary edema, I'm a great believer in plasmapheresis. So we did plasmapheresis of 3 cycles. Because there was an acute renal failure, she went in for a dialysis. 5 cycles of dialysis had to be given. Multiple transfusions was given. The patient stabilized and finally was discharged on day 10. The third case is a 29-year-old gravida 4 para 1 living 1 abortion 2, BOH, previous LSCS with anemia, oligamnios. Since her NST was non-reactive with a normal Doppler, and she also showed up with fever, which was possibly due to an upper respiratory tract infection. The blood investigation showed HB of 7.9. Total count was within normal limits. The platelet counts were low. Pulse was 120 per minute. Now, because she had a severe tachycardia, she was referred to my maternal fetal medicine unit. She underwent LSCS Okay, post-operative, is it time to stop? Then I can stop, no issue.
Yeah, I think.
Yeah, we stop?
Vidya ma'am,
No, I think you can take a
continue
few
this. You continue this.
slides.
sir.
You can go ahead, Prakash.
Yeah,
Because
yeah.
this is a
In
different
Yes,
different
yes,
one.
this
cases.
you
Let
can
him
finish.
continue. Dr. Prakash,
Okay,
you continue.
post-operatively
Yes.
bleeding was excessive. She was controlled with oxytocin and platelet transfusion. The fever settled after 48 hours. Platelets were 1,43,000 on day 5 and she was discharged on day 7. So we thought that was the end of the problem, but it was not. Patient was all right till 1.5 months post-delivery. Then she complained of generalized weakness and breathlessness, which was insidious in onset and start progressive from the last 1 week. And her HB, PCV, everything was normal at that time. And the 2D echo showed a left ventricular hyperkinesia with an ejection fraction of 18%, giving us a diagnosis of postpartum cardiomyopathy leading to a dyspnea. She was admitted to ICU, treated with NIV, fluid restriction, diuretics, LMWH, and beta blockers, and she improved clinically and was discharged in a stable condition. So the common causes for acute respiratory failure in pregnancy include pulmonary, especially asthma, pneumonia, pulmonary edema, and ARDS, pulmonary embolism. Then cardiac will be peripartum cardiomyopathy or valvular diseases, neuromuscular, myasthenia gravis. I've had at least 2 patients with myasthenia gravis who went in for respiratory failure and Guillain-Barré syndrome. Obstetric, amniotic fluid embolism, preeclampsia HELP syndrome, or it could be iatrogenic because of us, like magnesium toxicity or excessive fluid resuscitation. Now, specific to pregnancy, we mainly have pulmonary edema. Remember, when you're giving tocolysis to a patient, always look for pulmonary edema, ARDS. ARDL is related to placental abruption, peripartum cardiomyopathy, amniotic fluid embolism, and once in a way, a trophoblastic embolism could occur. The venous thromboembolism risk are always increased by pregnancy. The management strategy is always stabilize the mother first. Maternal stabilization is the best fetal therapy that you can offer. The initial stabilization consists of A, B, C, D, E. There's the airway, breathing, circulation, disability, and exposure. A multidisciplinary care is definitely required. And oxygen support is very important. Remember, we are going to have a difficult airway in intubation in pregnant patients, so be prepared for it. And if there is a rapid desaturation, hypercapnia, neuromuscular weakness, amniotic fluid embolism, ARDS, first do an intubation rather than a non-invasive ventilation. The mechanical ventilation settings are very important because permissive hypercapnia is not well tolerated in pregnancy. So you need to make sure that you give her enough PEEP so that whatever fluid comes into the lung gets pushed back into the circulation. The extracorporeal membrane oxygenation, the ECMO, is now used for most of the severe cases. Of course, we need to treat the underlying causes, whether it's pneumonia with antibiotics, embolism with LMWH, asthma, ARDS with ventilation and lung protective methods of ventilation, magnesium toxicity, stop magnesium, amniotic fluid embolism is mainly supportive, and preeclampsia, of course, you have to give magnesium antihypertensives and diuretics, and of course, deliver. Now, the fetus is very important to be considered. And if there is a cardiopulmonary arrest occurring with a respiratory failure, we need to be ready for a resuscitative hysterotomy. So in summary, assess and secure airway and oxygenation, obtain ABG, chest X-ray labs, identify the cause, whether there's pulmonary embolism, pneumonia, pulmonary edema, and so on. Initiate appropriate therapy, monitor fetus, engage multidisciplinary team, avoid delays in imaging therapy, keeping pregnancy care in mind. And remember, dyspnea is common in pregnancy, but not hypoxia or hypercapnia. Always keep amniotic fluid embolism and pulmonary embolism on the differential for a sudden decompensation. And if you follow this, you are definitely going to get a good outcome. Thank you very much for a patient hearing.
Sir, thank you so much for the excellent presentation. I would like to say that Dr. Girija has given a very excellent presentation, how the physiology works in. And you have exactly in a respiratory, how the pathology and what are the causes are there that you have been highlighted on it. So basically, it's a very thin line from physiology to the pathology. But what I would like to say that we have seen lots of respiratory failures, though in the COVID also, but nowadays also, if you can say that severe hypertension, hypertension, then severe preeclampsia, then heart diseases, cardiomyopathy. These are the diseases again coming with the worst clinical scenario. So it is very important to have a look with a good clinical examination. Just put a stethoscope and just look at that RS, respiratory system or the cardiovascular system, rather than going directly onto the per abdomen examination. That is one important thing. And there is a definitely role in that ki whenever you have any doubt, shield the abdomen and do the X-ray. Or whenever it is needed, is that rather than the patient is having a lots of consolidation revealed on the postmortem report, such things can happen. We are with the death audit meetings, and these are the things also coming up also in that. So it is very important whenever we are managing such patients at a nursing home, then definitely when we feel that there is a decrease into the saturation and there is more of the tachypnea, don't waste the time, go to a referral center and let it go to the center where you have all the team approaches in that. It's multidisciplinary. It's not only the cardiac system when there is either hypercapnia or the hypoxia is there. In short, you have highlighted very nice all the etiology and all the causes of that. How one should go with the mechanical ventilation, because that is the one important thing where you are referring the patients to the higher centers with the ambubac. That also it has been treated in that, and very nicely told about the pulmonary embolism or the asthmatic fluid
Dr.
embolism.
Rajeshri, there are
Yes,
two
ma'am.
questions in the chat box. He can
Yes.
answer only in chat box because they are very important from their point of view. Those two questions,
I
please
think it is
take
for
those
the
also. Yeah.
where I can't see that.
Yeah,
Sir,
one is the thoughts on the bromocriptine in peripartum
Sir.
cardiomyopathy.
Yeah. Okay.
Should we consider
Bromocriptine
it
can definitely be used
in
in
preeclampsia? Yeah.
Bromocriptine can definitely be used in peripartum cardiomyopathy. There are many, many articles that showed its usefulness. The problem with us is that whenever we use a bromocriptine, possibly if we have a baby with us, it does become a little difficult for lactation. So that is why I don't use it as a first line of management. I wait. If the things don't settle down, then we start using bromocriptine. The second question what I see here is that about
epidocin and rotin.
Epidocin and rotin. Please remember that these drugs are not allowed as per even the Indian drug formulary. You should not be using them because they are known to cause problems. So please don't use it. I know when I was a postgraduate, I have used epidocin like water. But I have not used now. For many, many years.
We also too stopped of using all these things. Don't be in a hurry to give the epidocin or the rotin to facilitate the cervical dilatation and all those things. Let it be go its natural way. If there are uterine activities there, it will dilate the things when the fetus is in a proper progress of the presentation, engagement, and the progress of the labor. Before that, I think before using this also, we should highlight on the alert line and the alert action. That is very important in the all labors, all difficult high risk cases.
Prakash, if I can add here that there is some evidence to support in those deaths which have been attributed to embolism. There was use of epidocin, and these are essentially smooth muscle relaxants, and that might open up the vascular sinuses in the uterus, and it might lead to amniotic fluid or other embolic phenomenon. So that is the reason why it has gone out of practice. And as the experts are saying, we are not using relaxants now, and we are smooth muscle we are depending on uterine contractions and normalizing its action to dilate the cervix.
True.
So that is how the current management goes. We shall move on. I think
let us move ahead because there will be a lot of this one. So I invite now Dr. Aruna Suman. Yeah.
Just I would like to thank to Sneha ma'am, Shobha ma'am, to yourself and Dr. Parag sir,
At
ICOG
the end, we will have a Thanksgiving session. Be there till end. Dr. Rajeshri. So I invite Dr. Aruna Suman to introduce our Dr. Pratima Mittal. She will be talking on shock in pregnancy and intensivist viewpoint at the bedside. So Dr. Aruna Suman.
Yes, ma'am. Thank you. And thank you for the opportunity, Sneha and everyone. Thank you. Vidya Dhobi ma'am, thank you. And it's my honor and privilege to introduce Dr. Pratima Mittal, ma'am, Professor and Consultant, Department of OBGY, VMMC and Safdarjung Hospital, New Delhi. She's Honorary FRCOG from Royal College, exemplary work done in women's health, former HOD, Department of OBG, Safdarjung Hospital, Vice President Foxy, 2018, President Association of OBG, Delhi, AOGD, 2015 to 16. And
I think
awarded
that's
Best
enough,
Society of
Aruna.
Foxy.
Aruna, I think that's enough. I just like to
Ma'am,
add that I am retired now, so it is
I
ex-professor.
know, ma'am, I know, ma'am, and I keep following your
Professor
talks.
doesn't retire. Professor
Madam,
doesn't retire.
you will never retire from
Professor
teaching,
is-
madam.
Professor, teacher,
Yes,
they
right,
doesn't
right.
Professor
retire.
is
It's your
always
love and
Professor
affection which you.
lifelong.
We'll start.
Professor
We'll start
is
your
always
talk.
I want to share
Professor
my
lifelong,
slides. I
ma'am.
want to
Yes,
see.
yes.
Welcome you.
Can I share my
I welcome you,
slides?
ma'am.
Can I share my slides?
Yes, ma'am.
Share. Can you see my slides?
Yes, ma'am.
Yes, ma'am. Yes.
I'll make a.
But you
make
have
it.
to.
I'll make it.
Yes. Slideshow. Yes.
Yeah, just a moment.
Yes, ma'am.
So today, first of all, again, I would like to thank Dr. Sunita, Dr. Parag, and ICOG team, and Dr. Sneha, and of course, Shobha, Vidya, all of them, I'm really grateful that they recognize, Safdarjung Hospital as a, this good source of critical care, which is being given here. So I would just start my talk. Sneha has given me a talk, Shock in Pregnancy, an intensivist viewpoint at bedside. So I will not be focusing on, what is the types of shock which we really, how to identify. I will not be focusing on that. So if you remember, if you know, all of you know that shock is defined as a state of circulatory inadequacy with poor tissue perfusion resulting in generalized cellular asphyxia, whether it is because of the decrease in hemoglobin or whether it is being the decrease in the oxygen saturation in the blood, or whether it is due to increase in the heart rate, or whether it is due to any decrease in stroke volume. All of these things leads to tissue hypoxemia, and which will lead to tissue hypoxemia leading to ultimately tissue death if not corrected. So in pregnancy, if you look, shock in pregnancy is definitely a life-threatening situation. Most commonly, it is due to hemorrhage, sepsis, cardiogenic causes, and less commonly anaphylaxis and neurogenic events. So if you look at the, from intensivist's point of view, what is it? That managing shock in pregnant patient at the bedside requires two things: simultaneous focus on two patients, the mother and the fetus, while navigating the dramatic physiological changes, which Dr. Girja has really highlighted well, and I don't have to go into detail of any of these changes, which are compensatory hyperdynamic state. And secondly, again, two things: initial bedside assessment and side by side doing the stabilization, which should go simultaneously. It is not that you have to make the diagnosis first. First, you have to stabilize the patient, and then you can think of making a diagnosis. So my talk will be focusing on mainly 6 points. One is rapid recognition at the bedside, targeted evaluation, immediate interventions, monitoring and support, obstetric priorities, and spatial concentration. So when we talk of rapid recognition at bedside, we have to look at the early signs, and we have to look at the scores which are available now and which we are in hospital. We are routinely using these scores. So how do we go about these scores? If you look at the diagnosis of shock, hypotension, mean arterial pressure less than 60 millimeter, very, very important diagnostic of shock. Narrowing of pulse pressure less than 25, tachycardia, shock index, very, very important issue, very easy to calculate. Now it is mandatory in our hospital. When the patient comes to gynae emergency, we tell them that you have to calculate shock index and write it like you write pulse, BP, temperature. It has to be like that only. And if it is more than 0.9, then we have to be really bothered that it is a shock, and we have to be very vigilant. Respiratory rate more than 22, cold extremities, and CRT again is a very good, test for doing assessing the fluid responsiveness also, and we can do this, very easily in the bed at the bedside. Then warm peripheries, you have to be clear that in septic shock sometimes the peripheries may be warm. So you don't have to just say that if the peripheries are warm, that she's not in shock. So we have to understand these physiological things. Altered mentation, whether the patient is cautious, whether the patient is responding to voice, whether the patient is responding to your, stimulus, all we have to see. We have to look at the kidney functions by seeing how much the urine you are getting, the patient is passing, metabolic acidosis. And if there is a metabolic acidosis, Dr. Mehta has already talked about, ABG analysis. So if there is a high anion gap, then we have to be really considered that patient is in shock. And of course, hyperlactemia, which signifies tissue hypoxia, and which is also a prognostic marker for the patient's mortality and morbidity. So in doing a lactate levels in a patient who is coming to your emergency and you're suspecting shock is must. About the scoring system, I'm not going to talk much in detail, but it is a modified early obstetric warning system, MEOS, because it should be put in your, in your emergency. It should be put in your labor rooms. It should be put in your HDUs, and your nurses, your paramedical, all should be well versed with these. I think there is another talk which is focusing only on the scoring system, so I will not go into detail of this. And then secondly, about the mental state. In this obstetric Q-SOFA score is very important. Again, I will not talk much about it because you will be discussing it in a later talk. So how do you diagnose shock? Again, the same thing: history, physical examination, monitoring, and non-invasive monitoring, all are important for diagnosis of shock. High index of suspicion and physical signs of inadequate tissue perfusion are the basis of initiating prompt treatment. If you have identified shock, if you have diagnosed shock, you will be initiating treatment as early as possible. And if the shock is, there are 4 phases. If the patient is in one reversible phase of shock, patient can be really managed well and we can save the patient. There are no laboratory tests for saying that this patient is in shock or not in shock. And initial management does not rely on knowledge of the underlying cause. So very important. Just don't think of diagnosing. Just manage the patient and then think of the diagnosis. Basic investigation should be said. The blood group, if not known, CBC, LFT, KFT, serum electrolyte, coagulation profile, and complete ABG with lactate level. You have to in many places, ABG does not include lactate levels. So you should always write that please do lactate levels when you are sending the blood for ABG, so that you can really prognosticate the patient's condition in future, and you can say that if the lactate levels are falling, that her mortality, maternal mortality will definitely decrease. And of course, very important nowadays, Dr. Mehta also talked about it, perform point of care ultrasound to identify the cause, to see the lungs, to see the chest, heart, all these things. And again, there is a talk on POCUS. So in detail, it will be discussed on that. So I'll not waste my time in that. Then again comes the targeted evaluation. So what is targeted evaluation? Quick assessment, which again, Dr. Mehta has talked about. There are certain overlapping, but these things are very important. So we have to assess the high airway. We have to assess the breathing. We have to assess for hypoxia, early oxygen supplementation if SpO2 is less than 95%. See, this is very important that in pregnancy, we have to see if it is less than 95%, we have to intervene. Circulation, again, assess two large bore IV cannula should be assessed. Rapid assessment for concealed bleeding or sepsis should be done. Disability, you see if there is an altered sensorium, agitation, and also check blood glucose. Maybe the patient is diabetic and she is in ketoacidosis, or she is in hypoglycemic shock. Then exposure, look for any signs of trauma, burns, rash, or concealed site of bleeding. So when you have done this targeted evaluation, then again, what are the other things you have to do? You have to assess the maternal fetal well-beings, but always think that shock treatment prioritize the mother, not the fetus. Fetus is also important, but we have to prioritize on the mother. Maintain oxygenation, initiate fluid resuscitation, position the patient, tilt the patient to the left 15 degrees or manually displace the uterus to the left to alleviate pressure of the inferior vena cava to improve venous return. We call it as LUD, and this all of you should know that whenever you are resuscitating a pregnant patient, LUD should be taken into consideration. How do we do it? I think Dr. Girja also talked about it, that if you're on the left side, you put both hands and put it on towards you. And if you're on the right side, then from the one hand, you push it to the left. Perform point of care ultrasound, which again, we are focusing again and again that it is very important to do. All the HDUs, all the emergency units of obstetrics should have an ultrasound to identify the cause of shock, to assess free fluid and cardiac functions and the aorta status. All this is very, very important. Then what is the immediate intervention? Again, airway, patient's airway is ensured and high pressure oxygen using mask intratracheal intubation is required. Ventilation is checked and supported if needed. If patient needs a ventilator, it should be done. Then circulation, insert 2 wide bore cannulas, restore blood volume and reverse hypotension with crystalloids and colloids. An initial request for blood should be sent. Very, very important. And all the facilities should have O negative blood, so that if any situation occurs and blood is not available, at least O negative blood can be transfused to the patient. Then monitor the response to the therapy by BP, SpO2, urine output, and pH on ABG. Position the patient head down and LUD to avoid aortocaval compression. Vasoactive drug, Dr. Mehta has talked about these, are considered if the cause of shock is thought to be due to myocardial depression or profound vasodilatation, like in septic shock. And these drugs have no role in hypovolemic shock. If it is in shock due to hemorrhage, then these role of these drugs comes very late. Timely fluid resuscitation is very, very important and plays the most important role in management of shock. So, and again, we have to do the source control side by side. If we identify the cause, expedite surgical procedure or antibiotic management for PPH or sepsis, correct reversible causes like hypoxemia if it's due to obstruction, of hypovolemia, acidosis, or electrolyte imbalance. So if patient is in acidosis, if you think you need to give soda bicarb, you have to give that. So you have to collect all these things. So how do you do fluid resuscitation, which is a very, very important part of obstetric shock? Fluid resuscitation is the administration of fluid rapidly and in boluses to patients with acutely impaired hemodynamic status. If you see, fluid resuscitation requires in all cases of hypovolemic and septic shock, which are the most common shock we encounter in obstetrics. Conventionally, it is used when mean arterial pressure is less than 60, CVP is less than 8 in the absence of cardiogenic or pulmonary edema. Neither MAP nor CVP are good indicators of who needs fluid responsive. So how do you know fluid responsiveness? We have to be assessing. How do we assess fluid responsiveness? Very simple. Fluid responsiveness means that oxygen delivery to the tissues will improve after fluid administration. Fluid responsiveness can be measured by increase in cardiac output or stroke volume of 15% after receiving 500 milliliter of bolus of fluid. So how do we assess it? Determination of fluid responsiveness is done by passive leg raising test, which is very, very important. You just increase the pulse pressure of more than 9% on passive leg raising for 3 to 4 minutes is an indicator of fluid responsiveness. You just raise the leg of the patient and see that if there is a pulse pressure which is increased by more than 9%, that means this patient is fluid responsive. Then again, dynamic test, which we are doing routinely in our institution, in our critical care unit, in a spontaneously breathing patient. Again, if the patient is on ventilator, it is not important. It will not be really, a good test to tell us about the fluid responsiveness. So you have to assess the collapsibility of inferior vena cava with inspiration, and it is done by ultrasound. In spontaneously breathing patients, patient is likely to be fluid responsive if the IVC, inferior vena cava, measures less than 2 centimeter or in diameter, or IVC collapses more than 50%. So we measure the IVC in maximum expiration and inspiration, and if IC collapsibility is more than 12%, it's okay. But if it is less than that, then means it is another cause. But if it is more than 50%, that means the patient needs fluid, and patient will be really responsive to the fluid administration. Another test which I've told you was the capillary test, capillary filling test, which can be done easily and by pressing on the thumb or the index finger and just seeing that in what time it does come back when you release it. And you will see that if it is more than 2 seconds, then it means patient is needs fluid. Initial fluid replacement should be with an isotonic crystallite. Very important, don't just keep on giving any fluid, give 5% or give Himaxil, which we were giving earlier. So no, we will not, we do not advocate hydroxyethyl starch at any in any stage now. An initial fluid replacement should be with isotonic crystalloid solution rather than an albumin containing solution. The difference between crystalloid and colloids, I will not go into detail, but we should understand the problems with colloids, that is anaphylaxis, coagulation abnormality, acute kidney injury, very, very important. And of course, these solutes enter the interstitial space and hold the lots of water in these spaces. So these chances are that they retain the fluid for more than 24 hours, which is very, very not very, good for the patient. And again, which fluid? So if you look at this table, different types of fluid have been described. But if you look at the 0.9% sodium chloride and lactated ringer, they are more, more physiological, and we prefer lactated ringer lactate over normal saline because it leads to less of, electrolyte imbalance, and this is the fluid of choice for replacement. But if it is not available, you can give saline also. Normal saline 0.9% can be used. Then normal saline, as I've said, is accepted to cause a normal anion gap and metabolic acidosis of uncertain significance. And there is some evidence that normal saline may lead to renal dysfunction in patients with shock, but it is contraindicated. Ringer lactate relatively contraindicated in hyperkalemic patient and physiological similar to plasma. So if the patient is having hyperkalemia, you should go for normal saline, but otherwise you can go for ringer lactate if it is available. And of course, if you are giving blood, it is not advocated to give ringer lactate because it combines with calcium and binds with citrates in the blood and leads to coagulation disorder. So it is not advocated if blood transfusion is going on. How to administer, very, very important, should be given in boluses for fluid resuscitation, 500 cc to 1 liter bolus every 15 minutes, and reassess. Large bowl, 14 to 16 gauge cannula, no role of pink or blue cannula, always use orange, green or gray cannula. Then you have to use for, rapid transfusion, and always given boluses in the initial phase. Fluid should be warm. Hypothermia again has adverse effects. Oxyhemoglobin dissociation curve is shifted to the left, which impairs peripheral oxygen uploading. Shivering will occur. Hypothermia increases bleeding, and hypothermia increases the risk of cardiac morbid events. So we should administer fluid with the, should be warm, and we have got special, nowadays fluid warmer which are used for giving these fluids to the shock patients. Volume replacement, how much to be give? Crystalloid 3:1 in the ratio of 3:1 as per amount of blood loss. As I've discussed earlier, fast 500 to 1000 milliliter in 10 to 15 minutes, then reassess at 10 to 15 minutes. If blood pressure is less than, systolic blood pressure is less than 100 and pulse is more than 110, then again reassess, continue at same rest and reassess at 10 to 15 minutes. 500 ml in 20 to 30 minutes till 2 liters, then 250 milliliter bolus or colloids. Then if you already given 2 liters of crystalloid and patient is not, improving, then you can think of using colloids. And most maximum dose you can use of crystalloid is 2.5 liter and 1 liter of colloids. Until 3 liters, give 2, you should be arranging blood and you should be getting blood. So you give 2 units of PAP cell. So what is our goal of management when we are giving fluid? Our BP should be, arterial blood pressure should be 90 to 100, cardiac frequency, heart rate should be less than 100, central venous pressure more than 6, serum lactate less than 2, pH more than 7.2, and temperature more than 35. So these are the goal. If you are meeting these goals, then you can just shift to maintenance fluid. Then the fourth thing, so we have talked about 3 things now, till now. We have talked about diagnosis, we have talked of initial resuscitation, we have talked of, fluid, how to administer fluid, and now how should you monitor. So continuous blood pressure monitoring plus pulse blood pressure and respiratory rate are monitored, and adjust hemodynamic and metabolic targets for pregnancy. Very important. Dr. Girja told you about the hemodynamic and metabolic.
Sorry to interrupt you, ma'am. Your time is up.
I'll just take 2-3 minutes.
Okay.
2 minutes more, I think.
Okay.
I'll just 2-3 slides left. So a recording of parameters on a flow chart such as modified obstetric scoring should be done, documentation of fluid should be done, blood and blood product should be done, pulse pressure and shock index, I'm telling you again and again, very, very important. It is very useful for identifying early detection of hypotension. Lab studies like CBC, ABG, lactate, coagulation profile, all should be done. And bedside obstetric ultrasound focus will be very, very important to identify placental abruption, retained products, uterine rupture, or suspected pulmonary edema. Obstetric priorities, of course, we have talked about. We have to put the patient on continuous fetal monitoring and delivery, consider if maternal stabilization fails or intrauterine death is confirmed. And perimortem cesarean section in the event of maternal cardiac arrest after 20 weeks of gestation, PMCT should be performed within 4 minutes if standard resuscitation fails. And beside that, positioning, I have already talked it, left lateral position, left to avoid compression approach to avoid air to cable compression, and team approach is very, very important. Intensivist, obstetrician, anesthetist, neonatologist, all must be there. And communication to the family again is very, very important, and documentation of this communication and decision making should be recorded because it is important from medical legal point of view. So to summarize, I will say that an intensivist at the bedside treats shock in a pregnant patient by first stabilizing the mother, assessing and managing both mother and fetus, key bedside actions, including rapid assessment with point of care ultrasound, initiate volume resuscitation with crystalloid, apply the standard left lateral tilt or manual uterine displacement to improve perfusion in pregnant patients after 20 weeks, and identify the cause of shock, which in pregnancy can be hypovolemic, septic, cardiogenic, or embolic, and tailoring treatment to the type of shock and stage of pregnancy. Thank you. This is our critical care unit at Safdarjung Hospital. And if you have people have time, you must visit this unit. Thank you.
Thank you for the excellent and valuable inputs. Actually, should we follow the shock index or a modified shock index, including the mean arterial pressure?
Actually, we are following shock index, which is much easier to, follow when patient is coming to in emergency.
Okay. Ma'am, what about the MEOS chart to actually identify the critically ill woman?
See, MEOS chart is very, very important. If you look at the studies which were done in, maternal mortality by WHO, the main main gap which they identified was that the patients were not identified at the right time. Patients who were critical were not identified at the right time. So MEOS chart is very, very important, and all our paramedical and all our nurses, all our doctors, all our junior residents should be aware of them, and they should be filling them regularly so that it becomes a habit. I have not talked about it in detail because there is a next class on next talk on this scoring system, so I didn't talk about this in detail. Actually, we are following Carle's score, which is more evidence based, but routinely in all the places in UK and everybody, they are doing MEOS. So if everybody
we are also having MEOS, madam.
We are having MEOS, yes. Because this is more easier for even for our paramedical staff.
Carle is good enough because that is evidence proved, but still if anything you follow, but you should follow some,
something has to be followed. Yes. Yeah, Vidya, you can conclude, and then we can start. Vidya is there?
No, okay. I think Vidya has already moved out. So I think you can start with the second session.
Yeah, the second session also has extremely important topics. Just taking stock of the situations. We are exactly 12 minutes behind schedule, I think. No, 15 minutes behind schedule. Yeah.
Yes.
So we will make some attempt to rectify that. So I have for the next session 3 chairpersons, again senior Foxians, and very, very good in their field. And Dr. Bhagyalakshmi Nayak, welcome. She is Professor, Department of Gynec Onco, AHP GIC. She is also now Vice President-elect for the year 2027. She is the co-chair of Onco Committee of SAPOC and a governing council member.
We don't need to.
Then we next have Dr. Arun Borwa, very good friend again. Dr. Borwa, welcome. Seeing you after a long time. The consultant Apollo Fertility Center at Guwahati, and chairperson IAG, founder chairperson in Nisar, past president of Dibrugarh Society. Welcome to the masterclass. And then, of course, Dr. Soma Datta, consultant gynecologist from Kolkata at Woodlands Hospital, former assistant professor, Medical College, Kolkata. So over to all the three chairpersons, I invite Dr. Bhagyalakshmi to introduce the first speaker, Dr. Srinivas Gadappa.
Yeah, thank you so much, Dr. Shobha and Dr. Sneha, and of course, Dr. Vidya also for having me here. So I think I'll have to take back many things from your sessions. So because it's again a learning session for me. So introducing Dr. Srinivas Gadappa, he's a professor and HOD at the Department of OBG, Government Medical College, Sambhaji Nagar. So he has many accolades to his qualification. He is pioneered the respectful maternity care in the government hospital, and he is the master trainer in the gender integration and medical education. Published groundbreaking research in.
Good afternoon, madam.
Yes,
Thank you
sir.
very
Yes,
much
sir.
for your
Very much.
introduction. I
And
think
this is
we'll proceed
Yes.
because we are having
okay.
a lack
Okay.
of time.
Thank you so much. Thank you so much. Looking forward to hear
Yes.
from you.
So at the
Welcome, sir.
outset, I will share my this screen.
I think this is a very important topic. So early warning signs and obstetric CPR. I think every practicing gynecologist should know something about this, because once you embark on your practice, anytime you may be taken by a.
Yeah, we must know obstetric CPR. Yes.
Yes, we can see
Over
your
to you,
screen, sir.
Yeah, can you see my slides?
Yes, yes. You can just make it full screen. Yeah.
Yes, so good afternoon. At the outset, I would like to thank the respected chairpersons and Dr. Sneha Bhuyar, Madam, Vidya Thobi, ma'am, for giving me this opportunity. This is actually a CPR week going on from up to the 17th September. This week is going on, and it is being celebrated by National Family Welfare Bureau. Because previously the CPR we used to talk about ACLS and BSLS, but now the national team of our ministry has done the NELS, that is National Emergency Life Support thing. So we are our own guidelines. The difference between this CPR of ACLS and R is that now CPR is being talked for each and everything. So whether it is a trauma, whether it is a any disease or in obstetric. So for everything they have designed the guidelines. So let us see that is what is obstetric CPR. So learning objects will be to recognize how to say that when there is a maternal collapse, what is the cause and risk, and master ourselves for resuscitation and perform modified CPR. Now, cardiac arrest in pregnancy is rare but critical. It is said that 1 in 30,000 cardiac arrest occurs in pregnancy. And when we are dealing with this CPR in pregnancy, these are two lives. So there are two patients, one baby and mother, and there is only one emergency. So it requires prompt, high quality CPR with modification for maternal physiology. Because we have seen that physiology is changed in the pregnancy, so we require high quality CPR. And our aim is to maintain maternal circulation and ensure that the fetal oxygenation is maintained. Now, what are the causes responsible for cardiac arrest in pregnancy? So these are the common causes, right from thromboembolism, pulmonary embolism, heart failure, peripartum cardiomyopathy, hypovolemic shock, eclampsia, sepsis, and amniotic fluid embolism. So these are going to cause cardiopulmonary arrest. For pneumonic, we remember 5H5Ts. That is, it may be hypovolemia, hypoxia, hydrogen ion excess, that is acidemia, hypo or hyperkalemia, hypothermia. Then in T, it may be toxins, tension pneumothorax, tamponade, thrombosis, and thrombolysis. Now, what are vital signs and trends and scoring systems? So we were talking about different scoring system available, but the gold standard scoring system, which is universally followed by WHO and all other, is modified early obstetric warning score. That is MIOS scoring. So it is a modified early obstetric warning score. It is a systematic scoring system that tracks maternal deterioration through the vital sign monitoring and clinical indicators. So it can be monitored by anyone. It can be monitored by medicos, paramedicals, nursing staff, interns, MBBS doctor, and even in a postgraduates. So what is this MIOS scoring system is that it contains certain parameters like temperature, systolic blood pressure, heart rate, respiratory rate, SpO2, and level of consciousness. So these are all gross parameters and they are graded as 0, 1, 2, 3, or a chart is kept where green, yellow, orange, and red things are given. So if the parameters are following in the green, that means the patient can be observed 4 hourly. What are these? These are normal parameters like normal temperature, systolic blood pressure is around 100 to 199, heart rate is 50 to 100, respiratory rate is 9 to 14, and SpO2 is more than 96, and level of consciousness is alert. But as the parameters go on deteriorating, these severity increases, and we want to intervene this. So we require that we should monitor light from consciousness to everything. Now, what is this management depending on the MEOS flow chart? If the parameters are falling in the green, the routine monitoring every 4 to 6 hours. If the parameters are falling in yellow trigger zone, that is 3 to 4 score is coming, the inform registrar then raises in 30 minutes and consider fluids and antibiotics. If it falling in red trigger, that is score more than 5, it requires active obstetric emergency team. It require ICU transfer and address 4H and 4Ts, which are we are dealing with. And if it falls in the last, then it's important and you have to be very careful. Now there is another scoring system. This scoring system is used for organ dysfunction once patient revived and it is in the critical care. That is a SOFA score system. What is this? This sequential organ failure assessment. That is SOFA, sequential organ failure assessment score, that provides method to quantify severity of organ dysfunction in critically ill patient. While not exclusive designed for pregnancy, it helps in clinical gauge systemic impact of cardiac arrest and cardiac post-resuscitation care. So this is important when we are doing a critical care treatment in the ICU. Secondly, it requires careful interpretation due to physiological changes often used along the obstetric specific score. Now, what this SOFA score contains? It contains a respiration, that is PaO2, PFiO2. It contains coagulation parameters like platelet. It contains hepatic parameters like bilirubin, cardiovascular like mean arterial pressure, CNS, that is Glasgow's chroma score, and renal function, that is creatinine and urea. So if this is a score from 0 to 4, as it increases the score, the prognosis is poor. So you have to do a SOFA score in critically ill patient. The higher the SOFA score indicates greater organ dysfunction. When assessing pregnant patients, these criteria must be interpreted carefully due to significant physiological changes that occur during pregnancy. Now, recognizing the cardiac arrest in pregnant patient is very important. So, unique signs to mother are physiological changes during pregnancy can mask altered and traditional warning signs. So, sudden loss of consciousness with absent pulse, non-respiratory effort or gasping, absence of carotid or femoral pulse, cyanosis or pallor, despite of pregnancy's normal hypervolemia. The critical changes is pregnancy related factors complicated pregnancy. So these are the signs which can say that patient is in collapse. So what are the challenges when we are giving? The challenges is that airway, as already mentioned by the previous speaker, increased vascularity, edema, and this is difficult for negotiating the challenges. Chances of aspiration and ventilation difficulty due to compromised diaphragmatic elevation. So the most important thing in CPR one must remember is left uterine displacement. That is LUD. So it is a critical technique. You must do this LUD, then only you should start CPR. So what is this LUD? It can be done manually, displacing the uterus to the left. That relieves the aortic column completion and caused by the gravity uterus. So first step is to deviate the uterus to the left so that the aortic compression is reduced. This intervention is essential to improve venous return to cardiac output during CPR in pregnancy. That is the first step in CPR in pregnancy. Then what is this modified CPR positioning? That is left uterine displacement technique that we have seen. Secondly, this can be done by putting a wedge position, that is modification. That is put 15 to 30 degree left lateral tilt using a firm wedge under the right hip and the shoulder. So you have to keep the wedge of 15 to 30 degree on the hip and the shoulder so that there will be a left lateral tilt. Then compression adjustment. Modify your hand placement slightly higher on the sternum. Normally we keep at the lower border of the sternum. We are keeping now higher at the sternum above the gypoid process, accommodate the anatomical changes and tilted position. So this is the position we are giving a left tilt. We are giving the uterus pushing on the left side so that there is no compression and we are giving the CPR. Now, airway and oxygenation priorities are important. You require high flow oxygenation, difficult airway management we have seen, and tube placement. A lesser size of tube has to be inserted because of the laryngeal edema. So if edema is there, a size less, one less is important for endotracheal implantation. Then there is a reduced functional residual capacity. it causes rapid desaturation and pre-oxygenation is critical. So here high flow oxygen is required, and risk of aspiration is very important because of relaxed esophageal sphincters. So you should be very careful in a good conditions and a good ICU. Video laryngoscope is very important when you are using a CPR in a critically ill patient. Applying cricoid pressure is very important to prevent aspiration. And when there is intubation is impossible, consider supraglottic airway if intubation is very fast, and deliver 100% oxygenation. Now, chest compression is another important part when we are giving this CPR. So, the hand position should place your hand slightly higher on the sternum to accommodate the elevated diaphragm and enlargement. So, that is one. Second, compression depth. The maintain a standard of 5 to 6 centimeter depth despite the breast tissue. So depth should be 5 to 6 centimeter, and the rate of compression should be 100 to 120 compression. That is good quality standard CPR. And minimum interruptions. So limit pause and limit seeing the parameters in less than 10 seconds. In breathing assessment, if you look at chest, neck, and face, see for only 10 seconds. If abnormal breathing is there, cardiac arrest. So rapid assessment is required. Call for help is important. It is said that once you find that you should give call for help not only for your assistant but also 102. It is a free toll number. You should put your mobile on speaker and you should call 102 and you should doing resuscitation. Position is very important. Begin with left lateral displacement. Begin CPR and prepare all the equipment for defibrillation. So defibrillation, the joules requirement is 150 to 200. If there is no recovery of spontaneous circulation within 4 minutes. So if under CPR, if there is no ROC, that is a recovery of spontaneous circulation within 4 minutes, then you have to give defibrillation between 150 to 200 joules. The medications which we are using is epinephrine, that is 1 milligram IV or intraosseal or intramuscular within every 3 to 5 minutes. Then amiodarone 300 milligram IV bolus, then 150 milligram after antiarrhythmias are given. And calcium gluconate for treating hyperkalemia, hypocalcemia, and magnesium toxicity. So the key principle is the aggressive maternal resuscitation provide the best chance for fetal survival. Successful maternal resuscitation is the most effective fetal resuscitation. Now there is a small word about perimortem cesarean section. Time is a issue for both mother and baby. So perimortem cesarean delivery should be viewed as a resuscitative intervention for mother, not just as a fetal salvage procedure. Removal of the gravid uterus improves maternal cardiac output by 30% or more. So sometimes doing a perimortem cesarean section in resuscitation is life-saving to the mother also. It should be performed 4 to 5 minutes in decision time. So if the spontaneous recovery of circulation is not occurring within 4 to 5 minutes and there is a cardiac arrest, you must go for this perimortem cesarean section. So at the end of 4 minutes, if you are not getting the result, you must start delivering the baby by doing a perimortem cesarean section. The technique is that perform at bedside, do not transport to the operation room. Vertical midline incision from pubis to xiphoid. Classical vertical incision for speed. Continue CPR throughout the procedure. The goal is to relieve aortic compression, improve maternal cardiac output. So perimortem cesarean section delivery improves maternal survival even if the fetus is pre-viable. Removing uterine mass enhances resuscitation effectiveness by 30%. So post-recessive monitoring is next step. After that, you have to do targeted temperature management. See that for there is no hypothermia, there is no further hemodynamic complications. Identify and treat underlying cause. Then see for the what are the other causes that has caused cardiac arrest, like amniotic fluid embolism, eclampsia, hemorrhage, and treat that. And you require a multidisciplinary approach for ICU management. So you require obstetrician, cardiologist, neonatologist, and all other comprehensive people so that patient can be given best results. So at the last, the take-home message is that critical points for maternal resuscitation is successful cardiac arrest is the requires an understanding of pregnancy-specific physiology. Recognize early interventions. Use MIO score. Q SOFA score after the stabilization. MIO score will prevent lot of cardiac arrest. And if at all occurs, your team is ready, they can do it. Time is critical. Within 4 to 5 minutes, you should initiate this thing. Then train regularly because CPR is we require to give it very rarely, though it is a common complication. At your place, it may not be that common, but you must train it everyone, not only a doctor, but also the paramedics and everyone, and they should be made a part of a CPR team. So modified technique, that is left uterine displacement, is must. Team coordination, multidisciplinary are required, and always remember mother is the first. You resuscitated her, the baby can also be saved. And these are the drill we are taking with the postgraduate student in our institute also. We are taking for paramedics also. And most important, that this effective cardiac resuscitation is very important, and it will come only when you take repeated drills, if you use the drugs commonly, and if you keep the emergency box ready. So at the last, I would like to thank the organizer for giving me this opportunity to talk on this important issue. Thank you very much.
She's not told when.
Thank you very much, Dr. Gadappa. Thanks a lot. And the very, very commendable that you were able to keep to time in spite of such an important topic. So I now request Dr. Arun Borwa to introduce Dr. Muralidhar Pai. Yeah. Dr. Muralidhar Pai does not need any introduction. He is known to each and every student and almost every consultant. Dr. Arun, are you there?
I think
Yes.
he is the perfect match for this masterclass. A
Yes.
masterman is the right person for this masterclass, and I think I'll not like to introduce him because the more I introduce, the less it will be mean to him. So I allow Mr. Dr. Muralidhar Pai, the masterman of masterclass. Please go ahead and present. We'll sort it out at the end of the presentation.
Yeah, thank you.
As you all can see, he is the head of the Sikkim Manipal Institute of Medical Sciences, and he has led that particular institute perfectly well. It will be really underdone if I say well. He has been actually leading this organization to a new level, and I expect Dr. Muralidhar Pai to go ahead with.
Yeah, thank you, Dr. Arun and Dr. Shobha, for your kind words. So let me straight away go to the topic. I'll be talking on neurological seizure disorders. What it means is I will not be touching upon eclampsia at all. Both may look alike, but I will be not talking on eclampsia at all. I'll be talking only on neurological seizure disorders. What is a seizure? It's a paroxysmal, that means suddenly happening at random, disorder of the central nervous system characterized by an abnormal neuronal discharge. This is very important. And what is to be noted, it can happen with or without loss of consciousness. Some patients will lose consciousness only to gain immediately. Others may not lose consciousness at all. Epilepsy is the common name that we are giving. It encompasses different syndromes whose cardinal feature is a predisposition to recurrent, unprovoked seizures. Recurrent is the most important word here because this disorder happens repeatedly. And the second important word is unprovoked. You don't see don't have to have any provocation, even though the patient will have some aura, but it can happen suddenly as though it is unprovoked. Whereas in eclampsia, we have seen there will be some provocation, some flashy lights and things like that, but this is unprovoked seizure. The incidence is thankfully very less, 0.15% of all pregnancies. In India, it is 40% of epileptics are women of childbearing age. That is very important here because most of them may not be aware of the situation, they may not be on proper medication, or the medication may not have been altered in them. Nearly 2 to 3 million potential mothers suffer from seizure disorders. And we can classify this as focal, where they have origin in one area in the brain and affect a corresponding area of neurological function. So only that particular function is altered because it is very focal. It's not generalized. They can result from a trauma or an abscess or a tumor or perinatal factors, although a specific lesion is rarely demonstrated. If you can see a lesion, fine, you can blame that, you can treat that, but many a times you may not be able to see any lesion, but there can be a neuronal discharge, abnormal neuronal discharge starting from a single focal area, affecting only part of the body, not the generalized body. Whereas when we say it is a generalized epilepsy, they involve both the brain hemispheres and are usually preceded by an aura, as I said earlier, before an abrupt loss of consciousness. In generalized epilepsy, usually there is aura and a loss of consciousness also. What is to be noted here, it is hereditary. I have made it very bold and big. So it's a hereditary problem. The generalized epilepsy will always have tonic and clonic seizures, somewhat like what happens in even our eclampsia. There is loss of consciousness that occurs, which is followed by tonic contraction of the muscles and rigid posturing, and then by clonic contractions. Patient gradually returns to consciousness on her own, and she will remain confused and disoriented for several hours. This is typical of the generalized epilepsy. Then there is something called absence seizure. It's also called petit mal seizures. It's a form of generalized epilepsy only that involve a brief loss of consciousness compared to generalized epilepsy where there is a some period of unconsciousness. Here it's a brief loss of consciousness without muscle activity. That is very important. There is no clonic or tonic contractions in petit mal epilepsy, and it is characterized by immediate recovery of consciousness and orientation. When the loss of consciousness is brief, obviously there will be immediate recovery of consciousness and orientation as well. What are the causes? Usually it is because of a head trauma or alcohol and other drug withdrawals, cerebral infections, brain tumors, biochemical abnormalities, or arteriovenous malfunctions, and idiopathic. Epilepsy is usually considered idiopathic, usually diagnosed by exclusion of other causes. When you rule out tumors, infections, and other abnormalities, you will brand it as a case of idiopathic epilepsy. The preconceptional counseling is very, very important. As I said, the dose adjustment is very important here. Women with epilepsy have 2 to 3-fold risk of having infants with structural abnormalities or anomalies compared with unaffected women. So they have to be totally under control. Otherwise, you will have the anomalies in the fetus as well. And secondly, from the mother's point of view, seizure should be controlled preconceptually, preferably by monotherapy, again, to avoid structural anomalies in the fetus. Now, we don't know whether the structural anomalies are because of the epilepsy disease itself or because of the drugs that we use for the control of epilepsy. It could be both as well. It usually includes, the counseling includes valproic acid to be avoided as it is increased teratogenic effect. As I said, the teratogenic effect may be because of the disease itself or because of the treatment. In that, valproic acid is very, very teratogenic, so it should be avoided. And you can supplement folic acid 0.4 milligrams per day at least 1 month before the conception. I mean, likely conception, it's very difficult to predict the conception. But whenever you are planning for pregnancy, it is better to start folic acid. And dose should be increased to 4 milligrams when she becomes pregnant, from 0.4 to 4 milligrams once the pregnancy is confirmed. So let us look at what is the effect of pregnancy on epilepsy. Will it increase the frequencies? Research does not indicate any increase in the frequency of seizures due to pregnancy, although some studies have shown increased seizure rates with attendant mortality risk and fetal malformations. The incidence of seizures have been further controlled with newer refined techniques of prescribing the optimum dosage of anti-epileptic drugs. Increased seizure frequency is often associated not because of pregnancy, but maybe because of subtherapeutic anticonvulsant serum levels. Why this happens? This happens because of a lower seizure threshold or both, and these subtherapeutic levels may result from pregnancy-induced nausea, vomiting, decreased GI mobility, that diminished drug absorption and hypervolemia. So even though you are giving the dose which she has been taking before pregnancy, during pregnancy, it may look like a subtherapeutic dose. That's exactly why I was talking about we have to adjust the dosage once she becomes pregnant. Hepatic and placental enzymes also can metabolize the drugs, so this also has to be kept in mind. And there is increased glomerular filtration as such in pregnancy. This will hasten the drug clearance. Due to these three-pronged reasons, there will be subtherapeutic levels, and pregnancy calls for adjustment of dosage. Otherwise, you will blame pregnancy for increased seizure frequency. I hope I am clear about this. The following increase are seen due to epilepsy in pregnancy. That is now effect of epilepsy on pregnancy. We just saw whether there was any effect of pregnancy on epilepsy. We said none at all, except because of the dose adjustment issues. Whereas, what is the effect of epilepsy on pregnancy? There is a twofold increase in cesarean delivery rate. This is actually fear-driven, both from the side of the patient as well as from the obstetrician. And there is 1.5-fold increase in the preeclampsia and PPH. This may be metabolically related. And incidence of non-proteinuric hypertension, labor induction, and postpartum depression is also increased. This is neurologically mediated. Further, hereditary effect can be seen if there is epilepsy. We have already talked about it. An epileptic mother has 1:30 chances of producing an offspring with a seizure disorder, although the exact mode of inheritance is not known. Malformations currently, this is the major hazard that the pregnant epileptic mother faces, both because of the disease as well as the treatment that we use. The very notorious syndrome, what we call fetal hydantoin syndrome, when patients are on this, Hansen described it for the first time, and we see a combination of microcephaly, mild to moderate mental retardation, developmental delays, prenatal and postnatal growth retardation, facial clefts and dysmorphism, and finger-like thumbs, distal phalangeal and nail hyperplasia. So together it is called hydantoin syndrome. What are the other effects of hydantoin that we use? There's an increased incidence of congenital heart disease or heart defects, Wilms tumor, vitamin D deficiency, hypocalcemia and tetany, neonatal coagulopathy due to vitamin K deficiency, and this incidence of such anomalies is as high as 7 to 11%. Anything more than 10 is very bad. Let us see what are the other effects of epilepsy on pregnancy. It is believed that many anomalies are related to the mere existence of epilepsy itself. As I said, disease itself can cause. This is because these women have high risk for seizures, which may cause injuries, abruption, periods of fetal hypoxia when she becomes unconscious, and FGR and IUFT. Infants exposed to barbiturates are often drowsy and may suffer barbiturate withdrawal in the first week. What's the treatment? In pregnancy, the physiological increase in blood volume, nausea, vomiting, which I've already explained, decreased gastric motility, and non-compliance are important causes of decline in the circulating drug levels, whatever drug you are giving. This could aggravate the frequency of seizures, so careful drug level monitoring and adjustment is desirable. Further, phenytoin and barbiturates are known to accelerate hydroxylation reactions in the liver by inducing microsomal enzymes. As folic acid is the coenzyme in these reactions, there occurs a rapid turnover of folate, which could lead to a deficiency. That's why we have to increase from 0.4 to straight away 4. Hence, folate supplementation becomes necessary. Levetiracetam has become the wonder drug. It's a new anticonvulsant, not really new. We have been using it for quite a number of years now. Its exact mechanism of action is not known. However, it works by slowing abnormal nerve impulses in brain. It does not pose a major risk to the neurological development of the fetus. Given usually started with 500 milligrams twice a day orally, and it is usually increased up to maybe 3000 milligrams, not more than that. How to manage a given seizure? Of course, it is not totally different from management of eclampsia. We have to have pre-conceptual counseling, which I have dealt in detail, prolonged seizure-free period, taper off and discontinue antiepileptics prior to pregnancy. Grand mal epilepsy should be treated first with phenobarbital. If patients have complex partial seizures, then primidone and carbamazepine is worth the first try. During pregnancy, however, seizure control and she is pregnant, no attempt is made to change the medication or dosage. If possible, as I said earlier, monodrug therapy is preferred. Then trimethadone or valproate are not at all advisable because of their teratogenic effect. Folate supplementation with drug level monitoring should commence if possible prior to pregnancy. So during pregnancy, we encourage to take medication regularly, not to deprive herself of sleep. Should she experience excessive vomiting, she is advised antiemetics so as to ensure drug absorption. Anticonvulsant drug level should be frequently monitored and dosage is advised. Ultrasound, fetal echo should be done as usual. Vitamin K should be given from 34 weeks. Cesarean reserved only for obstetric indication and neonatologists must attend the delivery. Babies administered 1 milligram vitamin K after birth. In conclusion, epilepsy is not a contraindication to pregnancy, and cooperation between the doctors and patients often ensures a favorable outcome in most cases. Thank you very much.
Yeah, that was a wonderful, concise lecture. And I think someone has very truly said that the art of communication, the best seen when the art of brevity is combined there. And you have brought in a brilliant information in a very brief lecture and very comprehensive as well. Dr. Arun, kuch bolna hai? Shall we go ahead with the next speaker? Dr. Soma Datta to introduce Dr. Vani Isukapalli. And if time permits, at the end of the 3 talks, we'll take some questions. Thank you.
Madam, can I share my screen?
Dr. Soma Datta, if you are there, can you please come forward to introduce our, yeah, Soma?
Yes, madam. I
Yes,
didn't
please.
notice that my phone was in the mute mode.
Okay.
Let me introduce Dr. Vani, and she is the Additional Director of Medical Education. She is the professor from Andhra Pradesh Medical College, Visakhapatnam, having multiple paper publication and best paper. She won it twice in the state conference. So she will be speaking today on a very important topic which contributes to severe acute maternal morbidity. So over to you, Dr. Bani.
So thank you very much, madam. So I'll be sharing my screen.
Yes, please.
So am I having the sharing option, madam?
Yeah, you should be. You should kindly try.
Shreya, please make her co-host. Then only she will be able to do.
So hope my screen is being shown, madam.
Yes.
Yes, very much. Please make it slideshow.
Oh yeah, sure.
And happy
Madam,
Diwali
I'll
to you
start
too.
with happy
Yeah.
Diwali to all of you. Have a
Yeah.
healthy and safe Diwali.
Yes, thank you. Wish you the same.
Thank you, madam. So first let me thank Sneha Boyer, madam, for involving me in this critical care CME of ICOG. The topic given to me is acute liver failure in pregnancy and what are the challenges we have in the management of such a case. To define acute liver failure in
Sorry to interrupt you, ma'am. Sorry, ma'am. Ma'am,
Yeah?
please make it full screen, ma'am.
It's already in full screen.
No, it is not moving.
Ma'am, click on
Slideshow.
the
From beginning.
Okay, right. So is it on full screen now, madam?
No, you are not sharing right now. Please share.
Yes, okay.
Share your screen.
I'll do it.
Yeah.
So now, madam?
Yeah, make it slideshow.
Yes, madam?
Slideshow.
Slideshow.
Made it slideshow.
No, in the sense full screen option is there, no? The hourglass option, you click on that.
Yeah,
No, madam?
right.
Maybe your net is slow. So what you can do is increase the size of the slide and then continue. Go back, please.
So let me again start.
Yeah. Possible that there is some net issue. Because you are able to see and we are not able to see, that means your net is slow.
So, madam, let
again.
me continue like that because of.
Yeah, but increase the size of the slide. There is a
on
bar
my
down.
Madam, on my screen, it is full screen only.
Okay, please continue. Please continue.
No worries. Go ahead.
So this topic is on acute liver failure in pregnancy and what challenges an obstetrician will face in the management. To define an acute liver failure, it is a triad. It's a triad of coagulopathy as evidenced by PTINR more than 1.5 and abnormal liver function test and features of encephalopathy as evidenced by any degree of mental alteration. So with a triad of these three, we can define a case of acute liver failure. We have a big set of liver diseases which may happen in pregnancy, and we are more worried about the pregnancy related liver diseases because the mortality is very high, the morbidity is very high in these particular cases. Among them, we have hyperemesis gravidarum, an extreme case, intrahepatic cholestasis of pregnancy, acute fatty liver of pregnancy, preeclampsia, eclampsia, and HELLP syndrome. So I would like to concentrate on these gestational diseases more than the other entity which are pre-existing. They are pre-existing before pregnancy and continuing with pregnancy. In this, we have all the types of hepatitis, cirrhosis, any other autoimmune disorders, and all the rest are rare. But now we have a significant or sizable number of cases post liver transplantation state. And a few diseases may be coincidentally diagnosed during pregnancy.
Sorry to interrupt you, ma'am.
Yes.
Ma'am, your slide is not moving.
Yeah.
So now, madam?
Ma'am, can I share?
No. I think you need
Yeah,
to
you will have to send. My suggestion is, can we take the first speaker of the next session by the time Dr. Vani shares?
Yeah. Can do that.
So just let me share it again. So give me just 1 minute.
Okay.
Why this
See,
problem?
now it is moving. Now it is moving.
Now it is moving, madam.
You are on
Okay,
this
madam, now?
FIGO guideline. You are on the FIGO guideline. Yeah.
Yes, ma'am. Okay, ma'am.
Please continue.
Okay. So I'll continue like this.
Yeah.
Okay, ma'am. So all the material what I have taken are from the FIGO guidelines. It is a multidisciplinary approach. It's a multidisciplinary approach should be involving the obstetrician, hepatologist, anesthetist, or a critical care specialist, neonatologist, fetal-maternal medicine specialist. So everyone should be involved because this is highly critical case. Is the slide moving, madam?
No.
Yes.
Now it is moving.
Now they are moving.
Early diagnosis.
Yeah.
Okay.
Please continue.
So early diagnosis is very crucial and vital, and this itself is a major challenge in acute liver failure. For this, an obstetrician should have a high degree of suspicion. Why? Because in pregnancy, the liver function test may be interpreted slightly differently, and the other main challenge is to determine the cause of liver failure, because there are multiple conditions which can result in a similar change in the lab parameters during pregnancy. A simple slide showing that alkaline phosphatase increases by 2 to 4-fold during pregnancy. Fibrinogen increases by 50% during pregnancy, and there is a difference in the globulin, increase in the alpha and beta globulin part and decrease in the gamma globulin part. Of course, alpha fetoprotein will be rising in pregnancy. So this we have to keep in mind before interpreting the LFT during pregnancy. So this slide is going to show us what are the different presentations of liver diseases and the LFTs which are commonly diagnosed in pregnancy might end up with a fulminant or an acute liver failure. In the first trimester, we have hyperemesis gravidarum, which amounts to around 2% incidence, where we can see that the alkaline phosphatase, bilirubin, and the liver enzymes are increasing, but the bile acids are normal. In case of intrahepatic cholestasis of pregnancy, which amounts another 2% of incidence, here the most important is the elevation of the serum bile acid level. So that is the most important point of the diagnosis. In preeclampsia and eclampsia, the alkaline phosphatase is normal, the bile acids are normal, bilirubin not much of change, but the liver enzymes are increasing. In a HELP syndrome, which could be a consequence of preeclampsia, eclampsia, which is the most important entity, here also the alkaline phosphatase is normal, bile acids are normal, but here we see the bilirubin is elevated and the liver enzymes are elevated. The acute fatty liver of pregnancy, which is very, very unique, which has a lot of mortality and morbidity, both maternal and fetal. This is quite rare, but an interesting thing, limited only to the gestation. Here we have the alkaline phosphatase elevating, bile acids normal, bilirubin and the liver enzymes are elevated. The other important, the main important challenge is to know what is the etiology. So we know she's in a failure, acute liver failure, to rule out the etiology because the treatment is etiologically specific. We need to go for a specific treatment which is etiologically specific. The other thing is whatever diagnostic or therapeutic interventions we are applying for that particular case should be safe both for the mother and the fetus. The maternal outcome should take precedence over the fetal well-being in a life-threatening situation, and all cases need to be managed in an intensive care with a multidisciplinary team. The general management, so I'll be skipping this slide because I have another important slide. While managing a case, we need to focus on particular areas, keeping in view what are the possible complications after an acute liver failure. The possible complications could be neurological, ending up with hepatic encephalopathy, or hemodynamic instability with hypotension and cardiac dysfunction. Metabolic, this is another important, could be hypoglycemia or could be dyselectrolytes. And the other important area to focus is the infections. It can ultimately land up in pneumonia, UTI, or it can land up in septicemia, renal failure, and coagulopathy, that is a disseminated intravascular coagulation. So all these areas need to be simultaneously focused while managing an acute liver failure. So let us look at the etiology specific management. Acute fatty liver of pregnancy, very unique to pregnancy. We generally follow the Swan-C criteria. The Swan-C criteria has 13 variables, 4 in the symptom group, 8 in the laboratory group, 1 in the imaging group, and 1 in the pathology group. Generally, we don't rely on pathology, or we fear to do pathology because of the altered coagulation profile. So therefore, it is generally clinically diagnosed, supplemented by imaging. So among the criteria, 6 out of the 13 criteria, if they are present, we can diagnose a case of acute fatty liver of pregnancy. The other important gestational event is the HELP syndrome. Could be due to preeclampsia, or even without preeclampsia also we can find cases of HELP syndrome. It is nothing but a triad of thrombocytopenia, abnormal liver test, and with evidence of hemolysis. If all three components are present, according to Tennessee classification, we call it as a complete HELP syndrome. If anyone is lagging, or if it cannot be diagnosed, then we are going to call it as a partial or an incomplete. The other way to classify by Mississippi classification, grading them into classes 1, 2, and 3 depending on the platelet count, and looking at the other parameters which are definitely elevated, LDH and the liver enzymes. So these are the two ways to classify. The main differential diagnosis is between the acute fatty liver of pregnancy and health syndrome because they mimic each other in many aspects. But we need to understand on ultrasound, acute fatty liver of pregnancy has ascites in almost 40% of the cases, which is not there in case of HELLP syndrome. And hypoglycemia is a very, very important component of acute fatty liver of pregnancy. The other one is serum antithrombin 3. So this is reduced by less than 65%, is diagnosed mainly with thrombocytopenia. That is the most and the compulsory or mandatory component among the three important parameters. Then, so once we have any case of abdominal pain and vomiting, either it could be a HELLP syndrome or an acute fatty liver of pregnancy. Depending on the Swansea criteria of acute fatty liver of pregnancy, if you are going to confirm the diagnosis, then in a stable case, we may give a supportive care, but this stability is very, very rare in case of a acute fatty liver of pregnancy. Generally, by dictum, it is a progressive disease. So there is a progressive liver failure, and this case need to be delivered in an urgent way, and vaginal delivery should be the basic rule. And if you are suspecting HELLP syndrome, we generally diagnose it by the laboratory criteria. When the diagnosis is confirmed, when it is more than 34 weeks, there is no controversy at all. We generally deliver the woman. And if it is in between the 24 to 33 weeks, so this is a gray zone where it is depending on the expert obstetrician decision, we may either go to conservative management, but generally in majority of cases, we need to deliver because it is also partly a progressive disease. The other important thing is the various viral infections which may present as an acute hepatitis and liver failure. Among all the A, B, C, D, and E, we are more worried about the hepatitis E infection, which is an RNA virus, and it may pose a problem both in causing maternal mortality and perinatal mortality. The other important disease is intrahepatic cholestasis of pregnancy, generally diagnosed with the most important symptom of pruritus, typically presenting in the palms of the hands and the soles of the feet. Here, the mainstay of diagnosis is elevated serum bile acids to more than 10 micromoles per liter. So this is the only way or the most important way to diagnose it. And we have a stratification system. I think if any PGs have joined this, so this is important, and the new one, how to stratify the intrahepatic cholestasis. So it is stratified as mild, moderate, and severe based on the serum bile acids. If the bile acids are in between 10 to 40, we grade it as mild. Between 40 to 100, it is moderate, and more than 100, it is severe. So depending on the severity of the stratification, the ultimate timing of delivery will depend. Because in a severe case, we all know there is a high chance of unexplained stillbirth in intrahepatic cholestasis of pregnancy, and these cases are successfully being, we can manage with ursodeoxycholic acid to the extent or in the dose of 10 to 15 milligram per kg per day in divided doses. The other important is, so I think we can skip this slide. Nowadays, we may, or in the future, we may encounter pregnant cases after liver transplantation. So women with liver transplant should be counseled to delay the pregnancy for 1 year post-transplant, and pre-pregnancy counseling is mandatory. So this should include the discussion between the patient party and the obstetrician about the safety of the medications, the need of monitoring all the blood markers of the graft rejection, and increased rate of maternal gestational disorders, both gestational hypertension and gestational diabetes. This should include an appropriate screening. and for eligible cases, we should put them on low dose aspirin. I think this is another important slide for the postgraduates. This is the way to, as a prognostic scoring system. For any liver disease, we can apply this, a simple way of applying. One is called as a model for end-stage liver disease, MELD score. The score less than 6 predicts a favorable outcome. Anything more than 10 predicts possibility of decompensation in pregnancy. The other way to prognose a case is by looking at the ratio between the albumin and bilirubin. Score less than or equal to 2.7 means a favorable outcome, and higher scores will be associated with a shorter gestation and preterm birth and the worse maternal outcomes. The other way is a ratio between the AST to platelet. So this ratio of less than 0.84 predicts the prognosis of the pregnancy is good. Anything more than 0.9, probably it would be a worst prognosis. So these are the unique and a new models to predict the chances of the maternal mortality and morbidity in case of liver diseases. So this is in a nutshell, any pregnant woman with severe jaundice and deranged liver function, our job is to look at what is the probable diagnosis. When the probable diagnosis is achieved, then we have to go for etiology specific treatment. However, general measures are common in each and every case. Then coming to the obstetric management. In case of acute fatty liver of pregnancy and HELLP syndrome, majority of cases we have to terminate beforehand. Anything more than 34 weeks, there is no controversy. Anything between 24 to 33 weeks, then the dilemma comes when, how, and why to deliver. So both the answers for when to deliver, how to deliver, and why to deliver at that point of time need some obstetrics expertise. The other so I can conclude, I think, my topic. To conclude, acute liver failure in pregnancy, most important diseases are acute fatty liver of pregnancy and HELLP syndrome. We may get acute viral hepatitis also, coincidentally or pre-existing. Any acute liver failure of pregnancy has a significant maternal mortality, morbidity, and also perinatal mortality and morbidity. Many cases need an iatrogenic preterm delivery. Acute fatty liver of pregnancy and HELLP syndrome predominantly are the diseases in the third trimester. A high degree of suspicion is mandatory since the symptoms are non-specific and overlapping. Whenever we are diagnosing acute fatty liver of pregnancy, delivery is indicated once stabilization has achieved. But in case of HELLP syndrome, in mild HELP case or an incomplete HELP case, we may, in few cases, go for an expectant management. Multidisciplinary team should be involved. It is highly critical. And if we want to have a successful outcome, a multidisciplinary team should be involved in the care of the women. Acute viral hepatitis in late pregnancy, quite though rare, especially if it is hepatitis E, may pose problems in the morbidity of the mother, and rest others have a self-limiting course. A thorough clinical evaluation combined with serology is required to make a diagnosis of an acute hepatitis case. Mainly the management could be supportive. Very few require antiviral agents, only if the viral load is high. Maybe then tenofovir is administered. Otherwise, mainly it is a supportive role. So I think so this is my last slide. And acute liver failure definitely is a complicated entity requiring multidisciplinary team.
Yeah.
Because of the overlap, because of the
thank you.
overlap of the presentation and the investigation, definitely lab reports have to be interpreted so very
It
neatly.
was a very, very exhaustive, very good presentation. Dr. Soma, I think you agree with me, and I think we can now move forward because the time is not there for interaction. So let us wait for the next session to get over and then let us see. So please do wait. All speakers, we request you to wait till the end of the session. If possible, we can have some interaction. Over to you, Sneha, for the last session. Over to you, Sneha. Sneha, over to you.
Sneha, are you there?
No.
Hello.
Okay, anyway,
Sneha ma'am
Shobha,
is not there.
you continue for the next session, I think.
Yeah.
He is
Yeah.
not able to
Correct,
communicate.
correct. Yeah. So we in the session 3, I think can you please share the CVs
Yeah,
of the
chairpersons. Dr. Meena is
chairpersons?
here.
Yeah.
Yeah, I can
Yeah,
see
you
her.
can introduce. You can
Evening,
introduce. Yeah.
everyone.
Good evening, Meena. Yeah, of course, everybody knows you as a senior consultant from
So
Patna,
we
and
can.
we know you as a GCM now for ICOG. And of course, you have done excellent work as chairperson, and you were also the president of Patna Society, and you had a very illustrious year. Thank you, Meena, for being here. Next chairperson. Yeah, and she is somebody from our home state, Dr. Sushma Dev, a professor and unit head at Mysore Medical College and Research Institute. Welcome, Sushma. She showed a lot of organization capabilities in the Yuva Foxy last year. Welcome. Then we have none other than Professor Saswati Sanyal Chaudhary, very dear friend, Professor OBG, Gauhati Medical College. And of course, they backed the conference for the year next. So welcome, Shashwati. And I think your achievements are too many to hold inside this time. So I request now Dr. Meena to introduce the first speaker.
So very little is given, but I'm sure his talk is going to tell us all. Dr. Shashaya Tirupati, Professor of Obstetrics and Gynecology. Sir, he's going to talk on something very important, passive transfusion protocol, something that has made such a lot of difference in the outcome of PPH, and mortality and morbidity has gone down to 1 because now we're depending on not just the RBCs, the other blood products as well. And sir is going to highlight on this very important topic. Sir, over to you.
Good evening, ma'am.
Good evening.
Whether you can hear? Yeah, good evening, ma'am.
Yeah, please
I
share
am
your
Dr.
screen,
Sesha
sir.
Sai.
Yes, sir. Share your screen, sir. Sir, are you able to share?
Madam, please share from your side, madam.
Have you sent the PPT to the office, sir?
Yes, ma'am.
Then
Yes,
please
madam.
share. Please share.
Yeah. Actually, massive blood transfusion, that is also called as MTP. It is not medical termination of pregnancy, it is a massive transfusion of pregnancy. And whenever we required heavy loss of blood, we will transfuse during the hemorrhage the blood products within a short period of time. So this is called massive hemorrhage. Next, please. How to, but it's unable to change, madam.
No, you can say next and she will change.
No,
So next
sir,
is,
it's being changed. Yeah, it's being changed.
so these
You are
are the
not able
products
to
which
see
we
the
are
next?
using. Yes, madam. That
Okay.
RBC, plasma, platelets, cryoprecipitate, prothrombin concentrate, fibrinogen concentrate, and whole blood. These are the products we are using while whole blood transfusion. Next. In patients with obstetric hemorrhage, massive transfusion, that is about 10 units of RBC and it occurs in 6 out of 10,000 deliveries. And most common cause is abnormal presentation that is reported in 27% of all cases. So next, please. Indications for massive transmission. Massive transmission may be implemented in both trauma and non-trauma clinical settings like obstetrics. Next. So non-trauma, number 1 is obstetric hemorrhage. Number 2, gastrointestinal bleeding. Number 3, surgical complications. Number 4, vascular emergencies. These obstetrical hemorrhages, the pathophysiology is okay. Changes occurs in result of massive hemorrhage. There will be chances of deficiencies or problems with coagulopathy, acidosis, and hypothermia. These are the 3 which causes lethal triad in trauma. So we have to be very careful. Exacerbations of the coagulopathy as a result of massive transmission. Sometimes we are seeing that is RBC repeatedly we are giving and dilution factors which will cause less platelets due to transmission of more quantity of RBC. And as we are giving, it causes acidosis as normal saline is administered that causes toxicity from citrate present in as an anticoagulant. And cold 4 degrees temperature, the blood which we are giving. And another one is this hypothermia as a result of administration of fluids below the normal temperature, body temperature. Next. So what are the findings we are seeing is whenever there is abnormality, INR more 1.5 or systolic BP must be maintained as 90, hemoglobin 11 grams if it is there, and base deficiency that will be 6 milliequivalents might be there. Positive bedside ultrasound examination is required, and heart rate if it is more than 120, then we have to take massive blood transfusion as early as possible to control. Next. So we have to take the history, what happened. There may be multi-gravida and multiple pregnancies, and there may be some other weakness, anemia, heart diseases, other things also which is causing atony and severe anemia which we are seeing. And we have to see the physical exam. Sometimes they will be taking warfarin and other anticoagulants. And there may be anticoagulants, antiplatelets they might be using with heparin. So we have to assess the injuries such as penetrating trauma or the traumatic PPH, which we are seeing most commonly, and obtain vital signs as blood pressure and heart rate. These are the most important to see. Next. So we have to take the hemoglobin, and as repeatedly we have to see the hematocrit. Then any abnormality, we have to increase the transfusion as whole blood loss will be there. Next. So if there is coagulopathy, we have to see prothrombin measurements, activated thromboplastin time, and INR, whether it is increased or same, and levels of fibrinogen. That is important. Hyperfibrinosis is common in patients with obstetric hemorrhage. So perform laboratory screening in patients on anticoagulation or in these suspected of being anticoagulants. Next. So some of the anticoagulants they will be using, and sometimes we have to give vitamin K antagonist, and platelets functions can be assessed in patients taking a suspected or taking oral direct anti factor 10. We have to be very careful and we have to assess. And some of the drugs, edoxaban or rivaroxaban, consider measuring plasma levels of these drugs, anticoagulants. Next. And sometimes we have to see the factor 10, 10A, and other tests also we have to check. Next. So coagulopathy defined as the following: prothrombin time more than 18 seconds, activated partial thromboplastin time more than 60 seconds, thrombin time more than 15 seconds, median time from injury to arrival to emergency we have to calculate. So the quantity of blood loss we have to assess. In spite of that, the overall mortality will be 19.5% and mortality 46% in patients with coagulopathies. So we have to think what is actually losing and we have to measure better way. Next. Next. So we have to assess the fibrinolysis with the cutoff of plus or minus 3%. For massive transmission, in general, trauma patients will require some evidence of lab investigations and management. Next. So management as a routine, what we are doing is taking blood pressure, heart rate, and we are seeing the volume and hematocrit value repeatedly. Next. So another is deficiency of calcium. We have to maintain the range 4.4 to 5.4 milligram per deciliter. In patients ongoing bleeding, we have to plan for anticoagulations. And some people will be taking vitamin K antagonist, direct oral anticoagulants, XA inhibitor, and dibigastrin and antiplatelets. They might be used. Next. Massive transfusion protocols, common, everything we have to clinically assess. And this massive transfer protocol may involve ratio-driven transfusion or goal-directed. So next. So we have to inform all the staff, blood bank, and the hematologist and other specialties when we are doing the blood transfusion as a massive role. Next, please. Next. So another thing is fresh frozen plasma and fibrinogen concentrate. We have to calculate the RBC and hemoglobin when your target is 7 to 9 grams per deciliter. If it is 7 grams at that time itself is adequate, and transfuse FFP to maintain prothrombin time and activated thromboplastin time, APTT, that is less than 1.5. And normal control of all viscoelastic hemostasis assay we have to do. Next. And we have to administer fibrogen as per requirement with the laboratory findings correlating. Next. In case of obstetric hemorrhage, patient with obstetric hemorrhage consider transfusion. That is, you have to give more RBC and plasma and platelets. There is range of more RBC and 4:2:1 or 6:4:1. And we have to manage 10-oxalic acid to reduce the bleeding. Next, please. So 2 units of whole blood transfusion, that will be more adequate and immediately you can control the bleeding and platelets loss. And deep vein thrombosis also we have to control, we have to prevent. Always give O red cells. For example, the O negative cells with a AB sera, that is the universal blood, but it is not that easy to make. If it comes, that is the best for massive transfusions, or whatever the group O or A or B you can give. In case of AB, the preferably is B group because it is having less subgroups. Next, please. In case of RHD, the older age, sometimes you can give Rh positive blood also for Rh negative, but younger and reproductive age group always prefer to take O negative cells always. Next, please. And cryoprecipitate and anti-hemolytic factors, they are insoluble precipitates. You have to give fibrinogen or factor 8C, factor 8 von Willebrand's factor, or factor 13, or fibronectin. These are the required. We have to plan it as per requirement. Next, please. It is an assessment of fibrinogen concentrate to restore normal clotting function. So what we are doing is bedside clotting test and clot retraction test in olden days, and now also we are preferring to do that one. And by giving tranexamic acid, it stops PPH in most of the cases. Next, please. So whenever hemoglobin is reduced 4 grams per deciliter means it is a PPH, and transmission of more units of packed red cells that is required to intervene and to prevent the deaths. Next, please. Next. Complications of the and prognosis. So exacerbations of coagulopathy or metabolic complications because we are giving drugs which are reacting or this normal saline or ringer lactate, which are producing some other combinations precipitates, and complication due to citrate in blood and hypocalcemia while delivering is a high risk, and acidosis may be more severe and difficult to treat, and citrate to bicarbonate or process of lactate is seen. These are the complications what routinely we are seeing. Next. So we have to manage metabolic alkalosis, hypomagnesemia, hyperkalemia, hypokalemia, and restoration of RBC membrane, which is takes out the potassium. So hypokalemia is seen. Release of aldosterone, antidiuretic hormones, and catecholamines. We have to see that one. Whenever the potassium is low, you transfuse the potassium. Next. If it is cold storage, the blood is given, then it causes transfusion related acute lung injury, and transfusion not related to other causes of acute lung injury also will be seen. But most lung injuries, we have to give special care and ICU management. And sometimes we'll see pulmonary edema. Next. Next, please. So I was the blood bank medical officer at GMH for 18 years, but only 2 or 3 cases massive transfusion I observed, and most commonly before 2000, whenever there is rupture ectopic, intraperitoneal blood and serum is filtered and infused to the patient. This is done up to 2000 AD. And later, when better blood bank management came and more blood transfusions are coming, we stopped that procedure. And whenever there is rupture of uterus, when we are doing repair, sometimes in one case we require 18 units of the blood. And nowadays the best is SR cannula. When you are giving SR cannula at negative pressure, which holds better, atony and even traumatic PPH stops better by SR cannula, which is suction done 2 times and for 10 minutes difference. Then 24 hours observation. After 24 hours, we are removing the SR cannula, and it's saving a life.
Sir, can we
almost
request you
100%.
to conclude, sir, because we have 2 more speakers.
Yes, madam. So, next, please. Thank you. This is my army photo.
That
Thank you,
is
ma'am.
wonderful. Yeah,
So, sir
Sneha,
is
please
a
take over.
warrior. Yeah, warrior all the way, fighting the PPH with the massive transfusion protocols. Thank you, sir.
Thank you, ma'am.
Thank you so much, sir, for accepting our invitation, and thank you so much for your excellent presentation. Thank you so much.
Thank you, ma'am.
We can move ahead with the second session. I would request the chairperson, Dr. Sushma, to please introduce the next speaker, Madam Manjupuri. Dr. Sushma, I think, has been already introduced, but yes, a very vibrant personality from Mysore Obstetric Society. Over to you, Dr. Sushma.
Sushma, unmute yourself. Unmute Marco.
If you can unmute her, Shreya. I think she's not able to unmute herself. We can go ahead with madam. By the time you can start sharing your screen, madam. Welcome.
Thank you.
Yes. Yeah, she's unmuted now. Yeah.
Very good evening, everyone. It's indeed a great pleasure and honor to be part of this ICOG CME on a very important topic of critical care. So, and it's an honor to introduce. Am I audible?
Yes, yes, please go ahead.
Yes.
Go ahead.
Yeah, the
Continue.
news. I'm not able to see this. Honor to introduce Dr. Manjupuri on the current newer concepts in the managing the coagulopathy. She's a very well-known person and a scholar. She's been the professor of Department of OBGYN at SGT Medical College, Gurgaon, and she's the national president of NARCHI, and she has extensive work done in the field of OBGYN and been awarded with many incredible awards, and she has a lot of credit to her work, and she's a national mentor for Lakshya as well. And it's indeed a great pleasure to have you, madam, at this forum. And once again, I welcome ma'am. Over to you, madam, for your presentation. Thank you, Dr. Sushma, for that kind introduction, and thank you, Dr. Sneha, for having me here. So I'll be talking on newer concepts in managing coagulopathy. So we all know the importance of hemostasis following delivery. We know that the blood flow to placenta term is 500 to 800 ml per minute. Hemostasis following delivery is achieved by myometrial contraction and rapid closure of terminal portion of spiral arteries because of the fibers, the special direction of the fibers, formation of a fibrin clot at placental site. So now remember, if this does not work, a woman can become exsanguinated within less than 10 minutes. There are certain physiological changes which happen in the coagulation system in pregnancy to prevent, the damage because of blood loss, which is mandatory, which happens. And so that is why pregnancy is a hypercoagulable state. So what happens in pregnancy is that there is an increase in procoagulant activity. So there is increase in fibrinogen level factors 7, 8, 10, and 12. At the same time, there is a decrease in anticoagulant activity. So the fibrinolysis decreases and protein S activity decreases. So that is a kind of a system which saves them or reduces the amount of blood loss. Now, looking at the coagulopathies in obstetric patients, they can be congenital coagulopathies and there could be acquired coagulopathies. So acquired coagulopathies are the one which are more common, and of this consumptive DIC is something which we do come across, and we know preeclampsia, abruptio placentae, sepsis, amniotic fluid embolism, and return dead fetus, all these can contribute to DIC. Of course, we have washout or dilutional coagulopathy, which we have just heard in the talk, and likewise, we heard about liver diseases where there is decreased production, and then it could be because of certain drugs which we put the patient on, especially in those who have cardiac disease or replaced valves. So there could be, and then of course, some patients may have thrombocytopenia. It is not actually a coagulopathy, but it definitely interferes with, the bleeding and the clotting. Now, what are the concerns in pregnant women of coagulopathy? There is risk of postpartum hemorrhage. There is risk associated with regional anesthesia for cesarean section or labor analgesia. There is risk of surgical procedures in case you do a cesarean section in these patients. There's formation of hematomas, both vaginal and abdominal, based on the route of delivery. There is an increased risk of re-exploration for hemoperitoneum after cesarean section. Hence, the importance of rational replacement of blood and blood components in obstetric patients with coagulopathy. So if we look at healthy hemostasis, it is a complex process. The process of clot formation takes place at multiple levels with intricate feedback mechanism. So we need normal vasculature, we need platelets, we need coagulation factors. At the same time, we also need fibrinolysis, because whenever the clot forms, it should be lysed. Otherwise, everything will get clogged. So looking at the process of hemostasis, whenever there is a damage to the vessel, it exposes the collagen of the subepithelium. And on this collagen, the platelets adhere. And once the platelets adhere, they form the primary plug and they release certain chemicals. And these chemicals would recruit more platelets. At the same time, these chemicals will also activate the coagulation factors, which will then cascade and result in production of activated, prothrombin. Prothrombin will get converted into thrombin, and thrombin will convert fibrinogen to fibrin. And it is this fibrin which gets, forms a fibrin plug. And so it is platelets, the coagulation factors, including fibrinogen, all of this is required for achieving hemostasis. At the same time, when the coagulation starts, the fibrinolytic system gets activated. It converts plasminogen to plasmin, and this plasmin will then act on this fibrin clot, which was formed from the fibrinogen, and results in production of fibrinogen degradation products. If everything goes on fine, the renal system is okay, so these products are excreted through the urine. But in case, the patient, the trigger on goes and the circulating levels increase, these are D-dimers. So they interfere with the formation of clot, and they also result in decreased myometrial contractility, so more PPH, and they are also cardiotoxic. So this is important to understand, because, understand the importance. So in DIC, the first thing is that there is intravascular coagulation. So this is stage 1. So not every patient starts bleeding. They start with intravascular coagulation because of the activation. And because of this intravascular coagulation, the platelets and the clotting factors get consumed. And once there is decrease in these factors, it leads on to bleeding. On the other side, when coagulation takes place, the fibrin gets deposited and it thromboses the small vessels, and it can lead on to organ dysfunction. On the other side, the fibrin deposition also triggers fibrinolysis, which results in formation of FDPs, and they impair the myometrial function and lead on to further bleeding. So we might have a DIC patient who is in the first stage, and we might have a patient who is in the second stage or the last stage. So depending upon what phase it is, we need to treat these patients differently, and that is where the role of current concepts in identifying coagulation disorders comes. So the key principle when we talk about DIC is resolving coagulopathy. So we need to know which phase the patient is in, and that is how we need to kind of rapidly correct that phase, do rational use of components. Now, if you look at the traditional test for assessing coagulation, we have the static test. Of course, we have bleeding time, clot retraction time, although everyone has said that says that it is of no use, but I feel that when a patient is bleeding, you can always take a sample and look at whether it's clotting or not, and whether the quality of the clot formed is good or not. It is not a bad idea. Of course, you can send the sample for PT, APTT. It takes time for the reports to come. And by that time, furthermore derangement happens in the coagulation system. Of course, we can do fibrinogen levels, we can do D-dimer levels. And of course, in CBC, falling levels and falling platelet, falling hemoglobin and platelet together would also mean that some consumption is taking place. So when we look at the bedside ties, we have this Duke's method where we take a filter paper, we can keep touching every 30 seconds till such time it dries. And normally it would be something like 2 minutes, 30 seconds. Clotting time, we take 2 ml blood in the tube and keep tilting it every 30 seconds. And normally in 4 to 10 minutes, it should clot. And this is what is most important. So it tells you how much are the D-dimers circulating. Is it right? So this is, the clot should be strong and it should not dissolve. In 30 to 60 minutes, it should retract and the serum should separate. If it is not happening, that means already the circulating levels of D-dimers are very high. A fibrinolytic process is very high, and it is here that you need trans-succinic acid. So looking at the normal values, platelets, we know 1.5 to 4 lakh, and these are the levels of alarm, less than 50,000. Prothrombin time is INR is 1.3 to 1 to 1.3. And if you look at the fibrinogen levels, it is 300 to 600, and less than 100 is the alarming level of alarm. And D-dimer should be less than 0.05 milligram per liter, and more than 0.05 milligram is a level of alarm. Now, let's move on to the contemporary, a point of care testing of coagulation status. So we have TEG and ROTEM. Now, what is this? So thromboelastography, that is TEG, and rotational thromboelastography, ROTEM, are global tests which are performed on whole blood and to reflect the platelet function and coagulation. So these are dynamic tests. So when you're doing PT, APTT, it just tells you about the clotting factors, right? If you do platelet levels count, it tells you about the platelets. But here, it is a dynamic process. It tells you how the clot is forming, what is the strength of the clot, and how it is dissolving. So it is a dynamic test. So a real-time dynamic test. So it assesses the kinetics of clot formation, its strength, and its dissolution. So these can be performed using a device located at or near the place where the patient is located. It can be placed in the OT, HDU, ICU, rather than in the central lab. So you take the blood sample, put it on the machine, and within 10 to 15 minutes, you get a report. And then you kind of give the components accordingly. Whereas if you send it to a lab, it takes about 30 to 90 minutes for the test to come. And these tests can then be used to guide the transfusion therapy and assess the response to interventions. Now, this is how it happens. What is the difference between TEG and ROTEM? Both are viscoelastic blood tests that assess clotting, but they differ in their mechanical action. In TEG, it is the cup which oscillates. The probe stays the same. Whereas in ROTEM, it is the pin which oscillates. So that is the only difference. The tracings are the same. The tracings are the same. Although, you can't, you don't have the same values. They have, the reporting is little different, but the tracings are almost the same. So giving you a understanding of what you get when you do this test. So this is the kind of test which you get. So you assess the clot initiation, which is R. So from the time when you start the test, how much time does it take for a 2 millimeter clot to be formed? So this is R time, reaction time. Then you have the K time. K time is from 2 millimeter to 20 millimeter. How much time does it take? That is the K time. And the angle which is there between the baseline and this angle, or the line which is formed joining 2 millimeter to 20 millimeter, that is the alpha angle. Okay, that tells you the kinetics of clot formation, right? If in case the clotting factors are less, then this angle will increase. Okay, because it will take, it will decrease, it will take, increase, it will take longer time, right? Then we have the maximum amplitude. So this tells you how good is the clot, how firm is the clot. And then it also looks at what is the rate at which it is lysing. Is it right? So normally, we have LY 30. So that is a percentage of clot lysis after 30 minutes of maximum amplitude. So normally anything between 0 to 7.5% is normal, right? In case it is more than that, that means, the clot is lysing faster. So we need to give a fibrinolytic agent. So R is the reaction time, K is the clot firmness, alpha is the angle kinetics of clot formation. This is maximum amplitude, and this is the lysis. So these are the factors which we will assess and give replacements accordingly. Now, looking at some abnormal results, so this is what is normal. So you have R normal, K normal, maximum amplitude normal. So all this is normal. Now, supposing, let me look at this, a patient who is in DIC, stage 1. So she's in hypercoagulable state, okay, with secondary fibrinolysis, because FDPs are released, so the lysis is happening faster. So you can see the curve changes here. The curve changes here. Is it right? So, and later on, when the patient starts bleeding, so all the factors become deficient. Here, the factors are not deficient. So that is why the maximum amplitude is fine. And even the angle, alpha angle is okay. But here, if you see, the maximum amplitude is gone down, and you can see that the clot which is formed is, it is a very small clot. It is not a good clot. So it tells you that the patient is now in hypocoagulable state. So I'll just give you a little more understanding of this. So how do we decide what to be given at what value? So reaction time is time from start of sample to 2 millimeter clot amplitude. It is 78 to 110 seconds. That is normal. If it is more than 128 seconds, it means, if this is long, it means that coagulation factors are deficient. There is hypofibrinogenemia. So that means we need to give fresh frozen plasma and fibrinogen to these patients. Then we look at the clot kinetics, the clot formation time from 2 to 20 millimeter. Okay, so this is 62 to 82. If it is less than 65, then it is abnormally low. It again tells you that you have to give, it is more of hyperfibrinogenemia. You need to give cryoprecipitate to this. Likewise, maximum amplitude is contributed by the platelets. If that is low, you need to give platelets. And if the lysis time is higher, then it means that you need to give fibrinolytic agent, that is tranexamic acid. So this is a general, principle. And how do you replace if PT is more than 1.5? If you have to give the prothrombic time is low, you have to give 4 units of fresh frozen plasma. If platelets are less than 50, then we have to give platelets. So either 1 SDP or 4 to 6 RDPs. And if fibrinogen is less than 100, then you have to give 10 packs of cryoprecipitate. Yeah. So basically, another important thing which is come up new is that, the importance of fibrinogen levels. So initially, we all used to give fresh frozen plasma, but now is the time when we need to give cryoprecipitates, and also synthetic fibrinogen is available. And it is a very early predictor of severity of hemorrhage. And it is important that the level should be kept above 200. Is it right? If the level of fibrinogen is more than 400, then it has got a negative predictive value of 79.
Sorry, just a minute, Dr. Manju. Dr. Sushma, please mute. Sushma, please mute.
And in case the fibrinogen levels are less than 200, it means it has got a positive predictive value of 100%. So that means you should focus on giving cryoprecipitate instead of fresh frozen plasma. If you look at this, if you look at cryoprecipitate, so if you give 10 units of cryoprecipitate, you are giving only 100 to 200 ml of solution, and it will raise the fibrinogen levels by 100 milligram per deciliter. If for fresh frozen plasma, if you give 4 units, it would give 600 ml. So that means you're giving more fluid, and it will also raise the fibrinogen by 100 to 150 milligram per deciliter. And synthetic fibrinogen, which is freely available now, it is available as vial. It is available as 1 gram in 1 vial, and it can be diluted in 50 ml of water. And if you give 1 vial, it will raise the level by 100 milligram per deciliter. So it is a good practice to have synthetic fibrinogen. It got a good shelf life. So you should keep synthetic fibrinogen also available in case cryoprecipitates are not freely available. Then a word about antifibrinolytic agents, that is tranexamic acid. So if you see that, we know that whenever FDP levels rise in the body, fibrinolysis will increase. And we don't want the fibrinolysis to increase because we want the clot to remain there and firm. So that is why we need to give tranexamic acid. We give 1 gram over 10 to 20 minutes. We can repeat if the bleeding persists, but it should be given within 3 hours of the delivery of the baby. So my key messages are that anticipation is most important. High index of suspicion is required. Preparedness, we must have SOPs in place. Early diagnosis is very important, and timely management. Rational replacement based on point of care test in case you have, or clinical test, and use your judgment. Fibrinogen is a saver, and we should give fibrinogen earlier than late. Thank you so much for patient hearing.
Any comments from the chairpersons? Dr. Meena? I think, yes, yeah.
Thank
Yeah.
you, ma'am.
Yeah.
You've introduced to such a difficult topic,
Yeah.
and you've explained. I mean, that's really something new for us because we read about it. But I think more and more, because now it's something that is being introduced to many ICU. I think not only just the cardiology, but other people also started using it, and it's going to go a long way, helping us. Not just blindly giving 4:2:1 or any other thing, but then we can also be guided by what actually it is. And the way you have explained, it's really, really very interesting, and you made it easy for us all.
Yeah, it was done brilliantly, Dr. Manju, as always. And you have given a very clear message that ROTEM and TEG need to become an integral part of obstetric critical care units. And it is a small expenditure because there is a maternal life to be saved. So very clear message. Thank you very much.
Thank you so much.
Yeah, I could see Madam Sheila
Good
Mane.
talk.
Yeah. Please, your comments,
Yeah, as usual. Yeah. Good talk. Yeah.
Thank you.
Good. There is a question in the chat box, Dr. Manju.
Yeah, I will answer that. Yeah. So indications for synthetic fibrinogen. So basically, all conditions where we think that the fibrinogen is gone down, especially if you have a patient of abruptio placentae, right? And these are the kind of patients where we would like to give fibrinogen. So in case you don't have any cryoprecipitates, then it is a good thing to be given, because we want the fibrinogen levels to be above 200. So if you give 2 vials, that should be okay. I don't have any experience in giving. Dr. Josna is here. Maybe she can throw some light. I was a part of the discussion. Even Dr. Sheila Mane can give an opinion on that. We've been together about fibrinogen.
I have an experience of using, and recently, I have used now. And abruption, it is very useful because we know that the fibrinogen level really drops very fast in abruption. So if it is handy, and for any institute, to getting the blood products is not so easy, particularly in periphery. They have only PRBC. Even though they want to shift, in case they know that their patient and point of care test, as you said, even clot retraction test. I think our LDI initiative, we have come out with a booklet. I mean, I can share that. So in that, Dr. Nalini Mishra has done that point of care validation, which is published in FIGO also. That between 8 to 11 minutes, also if you find that the blood is not clotting, that is the time when you know that a fibrinogen is deficient, and we can just go ahead and give fibrinogen. That is simple point of care. If you have a lab, nothing like it, you will definitely get the values. As you said, that if the values are less, not to wait for FFP, cryo will also take time. So the message was very clear. Yes, I have experience of using fibrinogen, and it's really, really very helpful. And as Dr. Shobha said, cost does not matter. We are saving the life.
Yes.
And in Karnataka now, most of the district hospitals, the DHs have taken an initiative and made it available in district hospitals now. So that will really help, local purchase is done, and at least they are keeping 2-3 vials.
Yeah.
And one more thing we learned in our HOPE conference, Dr. Manju, that even if you have to give 2 grams, that 50 ml solution only you can add the other vial also. You did not add another 50 ml. So that 2 gram can go in that 50 ml and we can transfuse.
Perfect.
Thank you.
Thank you so
Yeah,
much.
and
That was
some experience on fibrinogen and especially on cryoprecipitate. I can also share. Recently, we had a case of AFLP where the INR had crossed 2. It had become 2.4 when she came, and we delivered her under the cover of cryoprecipitate. We gave her overnight, and when the INR came to 1.2, then we delivered her. It took a matter of few hours waiting, but then we were able to save both mother and baby. So like that, with careful individualization and TEG and ROTEM, I think very strongly we have to kind of, we have to push it forward. And the clot retraction test also, every postgraduate should know how to do and what are the phases and how to interpret and how to then, because once we do the CRT, we can immediately send it towards TEG and ROTEM. We know that it is required. Yeah, thank you.
And
Very
Dr.
well said,
Shobha,
Shobha.
just a
Exactly,
point here, just a small point.
Yes.
In liver, in case you have AFLP or you have hepatitis and you want to give, then I think instead of cryo is important. But I think whole fresh frozen plasma may also be important in these patients.
Yeah, we
Because
gave
other complications-
FFP
Yeah,
and
yeah.
cryo.
Yes.
We gave both.
No,
Because the hematologist said you give FFP and cryo.
Yeah.
And then only you
so-
deliver her.
Yeah.
So
No,
don't
madam,
deliver before because she bleeds.
that's where the is very important. So Dr. Manju has very beautifully highlighted, and we have the algorithms, that what to do next. And cryo, we see, the FIPTEM is a very useful test, part of the component of the ROTEM test. So FIPTEM value, if the A10 is less than 10 millimeter. So immediately we know cryo has to be given in these cases. And of course, then with that, when we interpret whom to give FFP, whom to give cryo, it is very simple to decipher even for our residents, because we put it on the notice boards there and they can just see the report and they interpret it quickly. Cryo, of course, will only have fibrinogen. So as ma'am said, for the liver failure, we many times need to give both, as was
Yes, we gave both. Yes.
Yeah,
She
and
actually she survived because when she came, we thought what will happen because the bilirubin was 15, 20 like that. AFLPs were in thousands.
I
So
think,
it was
Shobha,
really.
we one or two cases we have also given prothrombin complex.
Correct.
AFLP.
In
Yeah.
PPH, yeah. PPH. And also
Only madam,
and in AFLP.
So
In
now
AFLP.
I think today's
AFLP.
session, Sheila, if I may say today's session, we must be thankful to Sneha because today's session has built a platform for another masterclass on component therapy when you take over as
Which
chair.
I will do it.
Yes.
Absolutely.
So that will be done. Yeah, over
Thank
to Sneha. Over. We'll complete it, I think. Jyotsna can.
No, madam has already delivered to the best of her capacity. I am sure people have been, benefited. She has taken us through very basic investigations to the, higher testings. Definitely, yes, elastography and all these things are very, very important, and they are the upcoming tests now. Though point of care testing, as everybody is talking about, since our PG days, I'm sure all of us have done it personally, and that is why we know how to do and how to interpret, and we are very confident about it, especially the time which is saved. Immediately you get the results because you have done it yourself, you are sure. So you can start your management early, and that is how I think that is advantageous. Of course, if you have the facilities for going ahead with all this, the advanced testing, that's a matter of, in fact, great pride, as well as, ultimately the aim is saving the woman's life. So I think all of us agree on these points, and let us now move ahead with the next talk, or the last talk of the day today. Over to you, Dr. Meena, to introduce Madam Jyotsna Puri, because Dr. Saraswati is held up in some medical emergency, family emergency. So please
Can I
introduce
share?
Dr.
Can I
Jyotsna.
share my screen in the meantime?
Yeah, please.
Yeah.
Please,
No,
ma'am.
I would like to have her, though we all know Dr. Jyotsna Suri from New Delhi, and she's done a wonderful job in critical care. She's professor and unit head, critical care obstetric VMMC and Safdarjung Hospitals, Delhi, and Vice President AOGD 21 to 22.
Thank you, ma'am. Thank you, Dr.
Yeah,
Meena.
yeah. Okay,
I
okay,
think we'll
ma'am.
go
We've
ahead with
read your
the talk.
books and all, yeah.
Yeah. So, yeah, okay. So I think we should go ahead because it's quite late and I'm sure people are tired now. Lot of things have been discussed, wonderful things, and I'm the last batsman. So I hope people who are waiting will not be disappointed. Okay, so my talk is, and I
You
first
can
of all,
make it full screen, madam.
yeah, it's full screen from my side. You can't see it as full screen?
No. I hope everybody else
Is
can
it?
see it. Then it's okay.
Can others see it as full screen, Dr. Meena?
Dr. Shobha?
No, no,
Any-
no,
Not
Jyotsna,
as
Not on
full
full screen.
screen.
Now it is seen.
As full screen?
Now it has gone.
Now
it has
you
gone.
need to share it again, madam.
Okay, I'll do that. Can you
Yeah.
see?
Yeah,
Is
yeah.
it
Now it's
screen
full
now?
screen. Yeah,
Okay.
full screen.
Okay, thank you. So I want to thank Dr. Sneha first of all for giving me this opportunity and also for selecting such important topics, and that too this giving me this topic about the rapid ultrasound in shock. So this is now actually a very important part of obstetrics. We as obstetricians now are all of us are very used to handling the ultrasound, doing our ultrasounds on our own. But this particular component of ultrasound, is something which is not very difficult to learn, and it can actually make a big difference for management of a critically ill patient. So the rapid ultrasound, that is the rush protocol in obstetric shock, it is a systematic point of care ultrasound approach for rapid maternal resuscitation. From the many talks today that it is a rapidly progressive life threatening condition which is characterized by poor tissue perfusion and oxygenation. So there is a diagnostic gap in the sense that if you are going to do clinical assessment, laboratory tests, and imaging in the conventional manner, we will often delay the diagnosis. And here every moment, every minute is critical, and every minute counts in the maternal resuscitation. So over here, point of care ultrasound bridges this very crucial gap with real time bedside assessment. So, what is the rush protocol? Rush protocol is the rapid ultrasound in shock and hypotension. As you can see, RUSH. Now, rapid means you have to do, very quick examination. Mostly it is said under 5 minutes during the active resuscitation itself. And it is a point of care imaging without, for the pregnant woman, we are not worried about any radiation exposure. And the systematic framework to identify shock etiology and guide treatment are the benefits of following this particular protocol. Now, what do we require? So these are, basically it is your own, curvilinear probe, which you are all using, that is required, for doing the this rush sequencing. So you can see here, I've put this picture purposely that when we have to do, the rapid ultrasound here in shock, so these are the placements of the probe, for the cardiac views, for the lungs, then for the inferior vena cava views, and the 4 and 5 are for the Morrison's pouch and the splenorenal view. Then here we have the aorta and the bladder, and of course we have the pelvic ultrasound also, which we do. Now, if we have to do the DVT screening, then it is better that we should be using the linear probe. So, because the superficial structures are better seen with the linear probe. Now, the rush protocol organizes examination in any sick patient, there are 3 core domains that allow rapid classification of the type of shock and help us in the management and resuscitation. So the first component domain, as we call it, is the pump. The second is the pipe, and the third is the tank. So we take it, from the pump, pipe, and tank for us to remember easily. So we can all appreciate what is the pump. Pump is the heart. So heart is pumping blood, and it is pumping the blood into the pipes, that is the aorta. And then, we have the big, large veins, the peripheral veins also, which come into the pipe system. So when we have to see thromboembolism, whether there is a DVT, so that will come under our pipes evaluation. Then the tank. So tank is the storage. So tank, the main is it is assessing the fluid status of the patient. So in the tank, the very important evaluation will be the inferior vena cava, which is again, reflecting the CVP, the thoracic and the abdominal compartment, and the pelvic compartment, whether there is any fluid over there, any loss of, blood hemorrhage or fluid shifts. So, this is so I'll talk little more in detail, and then quickly we'll do 2 or 3 case scenarios with small videos to see what this, 3 compartments signify for us. So why focus in obstetric emergency? I think I've already said that it is very quick, bedside availability is there of the ultrasound machine, no radiation. It is a dynamic monitoring. So real-time visualization of the physiological changes, and side by side, you can even see the response to your interventions and helps you in the immediate decision making. So the tagline here is focus is basically the point of care ultrasound. So of that focus, we are talking of the rush protocol. It is now regarded as an extension of the clinical examination in obstetric critical care. So let's see what all the pump can evaluate. So it is the cardiac evaluation. And let me tell you, it is not a detailed echo that we are doing. It is not, the cardiologist is not required to do this echo. It is the point of care evaluation by the obstetrician anywhere, anytime. And you just need to appreciate, you need to know, of course, you need to be trained, but you don't need to do the detailed structural evaluation of the heart when we are doing the point of care evaluation in shock. So what are we looking for? Main things you see are, number one, left ventricular contractility, whether it is a normal contractility, poor or hyperdynamic. Right ventricular size, whether it is the same as the left ventricle, is it dilated or is it smaller as it is normally? Then pericardial effusion, whether there is any fluid surrounding the heart, and what is the overall, global function of the heart, what is the overall picture. So this is called the eyeballing. We are not calculating any indices here, and I'll just show you with this video. You can see now here, you can see, this is the parasternal long axis view, and you can see very nicely that this is the heart contracting, and it is a, nice contraction. You can see it very nicely. This is the mitral valve, and sorry, this finger is coming. So this is the mitral valve, this is the aorta, and the left ventricular, the outflow tract, and that is the right ventricle. So left ventricle, right ventricle, this is that. Now here I will just show you for comparison the now can you appreciate how the heart is contracting here? So you see yourself the difference. Now here you see, again I'm showing you for comparison, and you see here. So you can, with the eyeballing, that the second the video, the heart is not contracting. There is a problem in the contractility, and there is in fact a very poor contractility of the heart, and it is also looking dilated. So we can immediately, this is something, it is the training, of course, you need to do few cases, but it is not something which we cannot learn. Okay. Now, after the pump evaluation, we move to the pipe. So in the pipe, the two main things we are to look for, one is the iota. Now, iota, we normally, in our young patients, it is not very common to have the aneurysms and dissection. Of course, if there is a background of heart disease and you are aware of it, but sometimes, the patient comes in shock and you really don't know what is the reason. So here, a quick assessment of the iota to see any aneurysm, dissection, features of dissection, or abnormal pulsatility. So it is critical for ruling out a vascular catastrophe. And then the second part in the pipe assessment is the DVT screening. So here the two major veins which we screen, that is the femoral vein and the popliteal vein. And we can do simply a compression, with your probe to see if there is a deep vein thrombosis or not. If there is a deep vein thrombosis and your patient is in shock, likely the etiology is the pulmonary embolism. So this was, the important things which we are looking for in the pipe. Now tank. So tank is the volume status. Now volume status is mainly evaluated by the inferior vena cava diameter and collapsibility. So because this is reflecting upon the basically what are the pressures, what is the CVP. So generally we are nowadays not doing any invasive test to see CVP, but this is a non-invasive test and it is a surrogate for the CVP and has very good correlation with it. So thoracic compartment, the other thing which we see in the tank evaluation is the thoracic compartment. So you will see the lungs, whether there is any pulmonary edema. And you can also look for any pneumothorax or pleural effusion. So when I show you the videos, I'll again show you what is the sliding sign. So the sliding sign will be absent in the pneumothorax. In the abdominal compartment, we will see, that is the part of the fast examination. 4 zones you have to see. Your Morrison's pouch, all of us are very trained to see the Morrison's pouch, splenorenal axis, pelvis, and pericardium. So free fluid will appear as anechoic, and you know immediately that there is some problem here, that there is fluid collection, which may be blood, which may be ascitic fluid, okay, or which may even be pyoperitoneum or some effective fluid. Then the third is the pelvic compartment. So pelvic compartment is again very, very important for the obstetricians because we assess for hemoperitoneum from ruptured ectopic or uterine rupture. So the POD is the area which we normally focus on when we are see the pelvic compartment. And we, of course, like to have the bladder window to assess the uterus and the adnexa also. So now here, this, whatever I have spoken, so this is kind of summarizing till now what I have spoken, that pump, tank, and pipe concept. So in the pump, you will see the hypercontractile heart or a small chamber heart if it is a hypovolemic shock. In a cardiogenic shock, you will see a hypocontractile, as I showed you in the slide before, and a dilated heart. Obstructive shock, again, you can have a hypercontractile heart. You may have a pericardial effusion because obstructive shock is normally due to either a cardiac tamponade or a pericardial effusion or embolism. So over here you may have a RV, that is the right ventricular strain pattern. RV may be dilated and there may be even a cardiac thrombus. In the distributive shock, the pump will be again, the heart will be hypercontractile in early sepsis and hypocontractile in the late sepsis. So in the tank, you will see in the hypovolemic shock, the IVC will be, absolutely, it will be flat, it will be collapsed, and there will be lot of variation. So it will be, during respiration, you will see during inspiration, it will collapse. Whereas in the cardiogenic shock, we call it as a plethoric. It is very dilated and it is not, it is not during inspiration we don't see that there is a collapsibility. Obstructive shock, again, it will be distended IVC, and distributive shock may be normal or a small IVC. Pipes in the hypovolemic shock, I have already said that there could be a aneurysm or a aortic dissection. Cardiogenic shock, normally the pipes will be normal. Obstructive shock, if you may get DVT if you are having a case of embolism. So normally in pulmonary embolism, you may have a accompanying DVT. In many of the cases, you do see DVT. Distributive shock, again, the pipes may be normal. So this is how you can interpret. Now I'll quickly do 2, 3 very, very short cases for you to understand how I'll put it together. So a P4 30-year-old woman, 60-minute post VBAC comes to us, and she has, she is in your labor room. She has sudden onset hypotension. Her BP has become 80-50. She has tachycardia, and she is also now having altered sensorium, and you are seeing that there is vaginal bleeding. Now you come quickly and you put your probes. So you are not sure, maybe there was some heart disease and she has collapsed. Many times unbooked patients come to us, we are not sure about their status. So we will now see the pump. So the pump you are here seeing, you are seeing that it is a small hyperdynamic, it is contracting quite rapidly. It is not a hypocontractile heart or a heart which is, not contracting adequately. Now we see the next. So here you are seeing the IVC. So IVC is the tank part, inferior vena cava. Now focus on the IVC. So you are seeing here that it is collapsing. You can see with inspiration, it is absolutely collapsing. So much of respiratory variation is there. Then we have put our probe near the Morrison's, at the Morrison's pouch we are evaluating, and you are seeing free fluid. So, you are able to make a diagnosis that patient has hypovolemic shock. Now you saw fluid, it was not just PPH, but you are now thinking in terms of rupture uterus with a hemoperitoneum also. So here, alongside the aggressive fluid resuscitation, blood products, you quickly decide to do a laparotomy. And yes, there was a fundal rupture, and rapid hysterectomy was done, and the patient could be saved. Now, this second case, Mrs. X presented to emergency as a para 1 obese post-cesarean, patient, day 3, with shortness of breath. So we are having lot of patients referred after cesarean with multiple complications. Now, this kind of patient comes to us very often. So on examination, her BP is on the lower side. Her heart rate is 110 beats per minute. Respiratory, rate is little rapid, and saturation is only 92% on room air. So, we see that there is a slight swelling on one of the lower limb, left lower limb. Now here you see this is the quick, the quick cardiac, views, different views are there, the apical view, this is the apical view. And this view, this view is the parasternal view. But here now, if you can appreciate, this is the right ventricle and this is the left ventricle. Now, normally the right ventricle is 2/3 the size of the left ventricle. That is, it is smaller than the left ventricle. Suddenly here, in this case, this single finding is so very important in this setup. The kind of background your patient came in. So you see this, very big dilated right ventricle as compared to the left ventricle, which should have been smaller. So it is this interventricular septum also you can see is shifting towards the other side. Now this helps us to make a quick diagnosis. Yes, this could be a pulmonary embolism. Now here when we did the evaluation, that was the pump. Here this is the tank, and you are seeing these, laser-like white lines. These are called the B lines. So these B lines are showing us that there is pulmonary edema. And there is, so this was also, the patient was in heart failure because of the massive pulmonary embolism, and therefore these B lines were there. And when we did her IVC, so you can see this IVC, it is quite plethoric. There is no variability as I had shown you in the first case. It is hardly collapsing during inspiration. And this was the compression ultrasound which we did with our linear probe. So, here you can see that the common femoral artery and vein. So with the compression also, it was not compressible. Normally, if there is no clot or thrombus, it compresses. But there was no compressibility was with the compression also. It was not compressible, and therefore we suspected a thrombus here. So this you can see, I am sorry, this video was not working somehow. I could not make it work, but we could, this one was the, when we put the Doppler. So this is the femoral vein, and these were the arteries, the deep femoral artery and the other one, femoral artery. And we could not we could not demonstrate the compression over here. So we suspected that this patient was a case of pulmonary embolism, and we immediately started the treatment for her. And of course, then we later on, after stabilizing her, we had gone in for the CTP, and diagnosis was confirmed. Now, this is the last case. So this patient came to the emergency postpartum day 5 with complaints of lower abdominal pain, fever for past 24 hours. She was in shock. Shock index was 1.3. She had high grade fever. Respiratory rate here was also high, and saturation was low. Patient was, pale and overall looking very distressed. Her uterus was also palpable with a boggy feel, and there was a foul smelling discharge, and the cervical os was open. Now here we see the normal cardiac contractility. So the heart is, contracting. There is no global, hypocontractility seen over here. So it is a normal contractility. I told you that normally in the septic shock, the contractility will be, normal. They should, in the early stages, late stages, of the septic shock, it will become a hypocontractile heart. So when we did the IVC, you can see how it is collapsing. So this was again a feature of septic shock. She was, totally hypovolemic. I mean, not it is not a hypovolemic. It is a distributive shock, but she was requiring fluid. So this particular test, when we do IVC, collapsibility, it shows us whether how much fluid can be given in this type of shock, and after giving each bolus we can repeat this IVC collapsibility and see. And then here in this, of course, this is all our forte. You can all appreciate the big, products of conception over here with which the patient has come. So we diagnosed it as a postpartum retained product of conception with, endometritis with distributive septic shock, and we decided to manage her on the lines of septic shock. So this was, the some of the examples I gave you. Now, in the end, I would just like to again, quickly recollect the advantages of our rush protocol. It distinguishes the different type of shock within 2 to 5 minutes. It guides in the fluid therapy, so that you don't give fluid in the cardiogenic shock, and in the obstructive shock, rather than, we need to give it more in the patients who are fluid responsive. Otherwise, we may harm the patient more. It is a standardized protocol with, consistency in the results and aligns with the maternal resuscitation guidelines. However, limitations, it is operator dependent. You need to have some kind of training, before you can start doing it confidently. And sometimes the body habitus, especially, in pregnant women with the large breast and, that part of the chest, it is very difficult at times to, do your echo and all. So in some patients, we do find it very challenging. Requires, the correlation with with the clinical picture. You must integrate it with the vital sign and interpret it in the clinical context. And however, it is a focused examination and not a replacement for formal imaging. So even when my residents are now, they have all learned, when they do the echo for a patient who comes in shock, it's not that I'm saying it is a replacement for a regular echo. It is only a focused ultrasound, but you need to do the detailed echo or the detailed ultrasound after the patient stabilizes. So in PPH, it guides us in fluid resuscitation to identify hemoperitoneum, to monitor response to uterotonics and the transfusion. In septic shock, it helps us to differentiate distributic from the cardiogenic pattern. Late cardiogenic, late septic shock will have the cardiogenic pattern also, the heart also, the contractility goes down. So over there, then we know we don't give more fluid, but we start the vasopressors timely. Amniotic fluid embolism, it helps us in guiding again the management, what kind of fluid is required and what kind of cardiac, support is required. And of course, in cardiac arrest also, it helps us to identify the types of shock. So the future direction, is very exciting. AI assisted focus with the machine learning algorithms are the, future. Of course, tele ultrasound has already come in a big way in many of the parts of the country, rural outreach. And also we can use this for the pre-hospital integration. So when the ambulance is going to bring the patient, portable ultrasound within the ambulances can quickly diagnose the type of shock and keep the people alert in the center where you are taking, that we think it is a hypovolemic shock or a cardiogenic shock. Please keep the facilities or keep the multidisciplinary team or your cardiology team available. So this is how it is very, very important, especially in our country where there are so many geographic barriers and resource constraints. But this simple thing, if it is taught and it becomes a part of our training for the obstetrician, it can really help in saving lives. So key takeaway, should be done in less than 5 minutes. 3 domains should be tested, and at least 25 to 30 scans should be done under supervision to require a degree of competency. So RUSH protocol is a transformative focus approach for obstetric emergencies. Its rapid, non-invasive and reproducible nature enhances maternal survival and supports evidence-based care. So thank you very much again for giving me this opportunity.
Explain and something so handy and useful for all of us. I think we are too much delayed. If there are any questions, Madam can answer them in the chat box. And Dr. Sneha, over to you.
Yeah. So I think excellent as always, Josna ma'am. I have been listening to you since so many years. I have been a big fan of you. We have invited you in a specially organized critical conference at Nagpur long ago. But then I have been a big fan of you for every session. I have been following you, and definitely it's a matter of pride for all of us that yes, I would like to congratulate you for this session as well as for your FRCOG, which you have just recently received. Especially, I would like to comment about the focus what people have the misunderstanding. It's not only the obstetric hemorrhagic shock or maybe the shock of unknown etiology, but definitely it guides you on every aspect and every etiological factor of the shock, including whether it is hemorrhagic, septic, thromboembolic, or even cardiogenic shock. So that is very, very important. And as you rightly said that AI assisted interpretation definitely will go a long way. I think that we see a bright future, and definitely it's going to help us in the management of critically ill women. So with this, I think we conclude. I would like to thank my dear friends, Dr. Vidya Tobi and Dr. Shobha Gudi, in joining hands together for convening this session. So Shobha, if you have any comments, you can please go ahead. Otherwise, I will conclude.
Yeah. I must congratulate Jyotsna for the very
you.
same,
Thank you, Dr.
for the
Sneha.
honorary
Thank you,
fellowship.
Dr. Shobha, for the kind words.
Yeah, it was wonderful session, and I think very practical, and we are all started dreaming of ambulances in India where mothers can be got from very remote places
I
with
think Foxy has a very big
every
hand for this.
facility at their disposal. including the
Oxygen
ultrasound
something.
machine. Yes.
Yeah.
Can I just, no, that we will have all PCP and DT problems. That is a different story.
Yes,
But
yes.
as you said, AI, no, Josna, I think as we don't have trained people in periphery, and when we have an ultrasound machine, the AI will be of help
Yes.
there. No?
Yes. Yes.
Because
And
even
that
if they are,
again, that again,
Definitely.
PCP and DT
yeah.
will be a problem in India, but I think it's very
No,
important.
in at least in an institute, when you have ultrasound machine, the AI can tell the diagnosis.
Yes.
So
yes.
because even if people are not trained, even if they keep the probe, the AI will pick up. Because
Yes.
recently I attended Dr. Asma Khalil's session in FIGO on AI. I mean, that was for a fetus, okay,
Yes,
like
yes.
growth and
Yeah.
all those things. So where the AI was already picking up and giving the dots, like bullets, that it has already picked up the BPD, it has already picked up the HSC, like that. So I think this condition, it will be very useful in India. If I think AI comes into this, no, then periphery, it will be very helpful. I think that one thing I picked up from this. So anyway, as usual, I think very thoroughly explained everything. Okay. Looking forward
It's
again for
also
your
possible,
participation next
Jyotsna,
year. Yeah.
it's
Yes,
also
yes.
possible for, technical, because what is happening today in ultrasound and in all imaging is the technical aspect is managed by, the technicians, right? And the images are interpreted by consultants. So maybe
Yes,
something
yes.
like that can be worked out, because
Yes.
then it may become different. Let us see, let us think of ways and means of, let us see what happens. The future is quite
As it is, they
exciting
do
with all
have the
these
options
possibilities.
of sending those images for,
Yeah,
even online you can send the images.
that's what.
Most of
So
the sonologists have been doing it. They're
yes,
sharing in their groups and even
yeah.
having the other opinions also. So I think even that is possible. But definitely it
Many
has a bright
interpretations are
future.
done remotely. So we must look
Yes.
at that possibility. Yeah, that is great. So I think Sneha, you can conclude. Yeah.
Yeah, so thank you so much, everybody. I would just like to officially acknowledge the presence and, of course, the participation of Dr. Sunita Tandulwarkar, Madam President, FOXY, Secretary General Dr. Suvarna Kadilkar, and, of course, Dr. Parag Biniwale, the ICOG Chairperson, and Dr. Sarita Balerav, the Secretary, Madam Sheila Mane, the Chairperson-elect. And all the speakers I would like to acknowledge. Everybody has contributed tremendously. I'm sure this is going to make difference in the practices of the obstetricians, though even remotely, I would say, because Dr. Girija started with the physiological changes, and Dr. Prakash Mehta has taken it, the respiratory problems during pregnancy, and a shock in pregnancy, the intensivist viewpoint, and at bedside by Dr. Pratima Mittal, early recognition of the shock, and of course CPR by Dr. Srinivas Gadappa. Muralidhar Paisa has very well discussed the neurological seizure disorders during pregnancy. And of course, Madam Vani Sakapalli has discussed a very difficult topic, acute liver disorders during pregnancy. And of course, the last session, which was actually the most important, the active management, that is taken up by Dr. Sheshasai sir, as massive transfusion protocol by Madam Manju Puri, the newer concepts in the management of coagulopathy, and Dr. Josna Suri, Madam has already discussed with us the role of ultrasound focus, and of course its role not only in the hemorrhagic shock, but all types of shock, and definitely the AI version, which we are eager to watch as well. So thank you so much once again, all the speakers, faculties,
Sneha,
the
though we
chairpersons,
exceeded
and of
time,
course
it
all
was
my
worth
friends,
it.
conveners. Thank you so much.
Yes, yes.
Correct.
I also agree for that.
Yes.
We exceeded time, but it was worth it. Yeah.
Yes,
Yeah.
Dr.
Okay
Vidya.
then.
No, it was all, means I learned many new things, and really it was worth to spend this precious time between 4 to 7:38, whatever it may be. Very practical, very practical.
Okay. I think we can end now.
Yes.
Thank you, Sneha.
Thank you so much.
Thank you.
Thank you.
Please
Thank you,
end.
everybody.